Councillor Dr. Hill, thank you for your reply. I fully appreciate the non-executive role of this committee, and the difficulty you face when agencies under scrutiny provide late and still incomplete information. Relevant to my supplementary question and to that late information, which I received this morning, is there further media and quite explicit statement today that in fact Melton does not need another GP practice at this time? Given there appears to be no, in their words on the information I received today, no guidance, no limits and no set ratios on almost everything they cover, can you ask the ICB what they think a reasonable number of GPs per patient is appropriate to a practice to provide a reasonable range of GP services? Secondly, does the committee agree that choice between GPs is not quite the same as choice between practices? Thirdly, is there a difference, and I'm using their data today, between the 63 practices which are larger than Latham House and Latham House, which is a single group practice? In other words, are some of these 63 bigger ones multiple group practices? And finally, bearing in mind that this process which Melton has been going through with the ICB in a collaborative manner, which was started by my friend and colleague Councillor Orson back in 2022, when it was, we both committed money, what facts have changed from then to now to suggest that whereas then a practice might well be needed, but now apparently it doesn't? Thank you.
Thank you. We can certainly ask about the ratio of GPs to patients, and your other point we'll have to ask the ICB people for you. I can't speak for the committee because they will come to their own conclusion later. Thank you anyway.
Thank you very much.
Okay, we'll undoubtedly come back to that under item 8. People pick up Mr. Allnutt's points. We'll move on to item 3, questions asked under standing orders by members. There are none. We have no other urgent items. Are there any declarations of interest? Mr. Poland.
Thank you, Chair. I'm employed by Edward Argo MP, the MP for Melton and Syston, who has been active on a number of things, including the St Mary's Birth Centre and the Latham House surgery issue.
Okay, thank you. No others? Okay. I'm assuming there are no declarations of the party whip. We've received no petitions, so it brings us swiftly on to item 8, primary care. So we've invited to the meeting for this part of the agenda the county councils that represent the divisions in the Melton area, because of course part of it refers specifically to them. So welcome to Mr. Innes, Mr. Lovegrove and Mr. Orson. The other Melton member, Mrs. Knight, is already a member of the committee. To present this report, we have from the Integrated Care Board, Yasmin Sidiot, Deputy Chiefs Operating Officer, Integration and Transformation. That's a good mouthful, isn't it? And Maya Patel, Head of Integration and Transformation in Primary Care. And we've also got with us Toby Saunders, who's the Chief Executive of the Integrated Care Board. So who's going to introduce it out of you three?
I will introduce this item. So for the purposes of today, what we've done is split the item into two. We've got the first half of the report, which talks about general practice access and an overall update around all things general practice and primary care for Leicester, Leicestershire, Rutland, and I'll talk about Leicestershire specifically for this committee. And then the second half of the paper that talks about Melton. So we'll take it in those two halves, if that is okay. Just to add some context, I know the paper talks about LLR. I think that is to set context, but we will specifically pull out from the report those areas that are specific to Leicestershire and provide some greater context in terms of some of the things that we are doing in Leicestershire, some of the challenges that we have got in Leicestershire, and what we're doing with regards to those challenges as well. I'll take the report as read, and what I want to pull out today as part of the report are some three, I think, key areas that I know committee will be very much interested in. One, which is around general practice access. This will be about the number of appointments that are delivered, what we've seen with regards to that, and some of the other areas of access that have come online since the last time we met and brought to this report to yourselves. The other area will be around GP workforce and overall primary care workforce. And lastly, we'll pick up some of the quality elements and the variation elements and some of the specific areas and challenges that we are looking at and working through. So I will make a start, and then I will bring my colleagues in as we go through that report as well. In terms of a overall access from a LLR perspective, as you can see in the report, that we have seen is over 2% increase in the number of GPP appointments that have been delivered across LLR. For Leicestershire, for the period that we are talking about in terms of 24-25 and up till this year, 25-26, April to October, we have delivered about 3.2 million appointments, which is about a 0.26% more than what we did last year. We were planned for at least about a percentage increase in those appointments, and we're well on the way to delivering on our plan as we had anticipated. And then you've got there some of the other information there with regards to Leicester City and Rutland as well, just for comparison purposes. The other area of access that we have got in across LLR and across the practices is what we call primary care network delivered enhanced access. So this is enhanced access of appointments that are 6:30 till 8 p.m. Monday to Friday, and then a morning of appointments on a Saturday as well. So these are additional and on top of the appointments that I have just mentioned. What we know for Leicestershire is that this is counted in hours. An additional 3,493 hours of appointments were delivered by Leicestershire practices as part of the primary care network. That's a 19% more hours delivered compared to the previous year as well. So what we definitely can see there is much more activity that is being delivered, much more appointments that are being delivered in terms of the demand that is out there from a general practice perspective. We also know, as part of the contract changes that happened from October of this year, online consultation became a mandated provision that all practices must deliver and provide the opportunity for online consultation to take place for non-urgent and routine and admin purposes. As a result of that, what we can see from October onwards particularly is about over 125% increase in the utilisation and the offer that is delivered by general practice across Leicestershire for online consultations as well. As you can see, that's quite a significant increase from the previous year. So if I give you a bit of a context around that, in 24-25 for October, for example, there was 30,763 online consultations delivered. For October this year, that's gone up to 69,338. So you can see that's more than double the amount of online consultation appointments that are being delivered as well. What I hope that allows people to see is, in terms of overall, from a practice perspective, how much more activity is being delivered through our general practice. And I know that despite this, we know that demand outstrips the capacity on a regular basis. So this is to say that despite all the challenges, we continue to strive to deliver what is needed and required out there for our population. I just wanted to also pick up Pharmacy First as well, because I know that we've talked about Pharmacy First previously through this committee as well. Although that's not general practice specific, but we know that what that does is provides additional capacity that supports and supplements what happens in general practice. In Leicestershire, all our community pharmacies provide and deliver pharmacy first. And we have seen a 92% increase in utilisation of those pharmacy first appointments in Leicestershire. What we know from an LLR perspective is that we are the highest number of deliverers of pharmacy first appointments and utilisation of that as well across Leicester, Leicestershire and Rutland. So that's another addition that really we're making most use out of, where we know that it absolutely supports our patient populations who require support or advice, but doesn't necessarily need that requirement to be fulfilled through general practice, for example, or through elsewhere. May, did you want to pick up?
Yeah, sure. Thank you and good afternoon all. So I think just going back on the overall appointments Yasmin talked about, this is around the access that gets measured in terms of how we look at practices across the board. That includes Leicester and Rutland, but obviously in particularly around the practices in Leicestershire. So alongside with that, to deliver those appointments, it's the workforce. We need to ensure we have the right workforce in place. The ethos and the concept still remains kind of high in terms of ensuring that the number of GPs operating in practices are kind of in level with what the number of patients are. However, we have to acknowledge there is a vast different roles, multidisciplinary teams that exist within general practices and beyond that now deliver care in primary care. So from workforce perspective, we have seen an absolute increase overall from April until the end of sort of December. In terms of the GP GP workforce, we have seen around additional sort of 6 recruitment of GPs, and I think more recruitment will take place during the Q4 because of the funding that will sort of allows the practices and the primary care networks to recruit them. So the workforce plans that each practice is working with the primary care networks has to submit very much looks at their sort of demand, the patient needs, the work in which they've got to deliver. That we are going to do we're doing a lot of work around the neighbourhood health program. How will they work in partnership with wider partners to deliver that? So they take all of that into consideration when planning for the workforce. So that's where we are in terms of the workforce. Around the another bit around is the variation. What we have is a program of work that very much looks at number of practices and how they operate. Now, each practices are independent contractors and they will have their own operating model, and that should be should be warranted in terms of how they design and deliver their sort of services. However, what we do is we look at from an overarching perspective around where there is unwarranted variation in how number of appointments, whether it's the patient experience, whether it's overall access and how those number of skill mix being utilized, etc. So we've got a program in place that very much looks at that. Also, we also look at the CQC rating, for example, and out of all of our county practices, there's one requiring improvement, one is absolutely outstanding, and the rest are rated as good. And that also allows us to sort of have a conversation around what is it that we need to do with individual practices to sort of bring them up to a level where we are confident in terms of how they're delivering care for our people. One of the other things that we are currently looking at working with practices is the number of DNAs. DNAs have risen in the past, and therefore that's missed opportunity for patients to access services in general practices. So currently a program is in place to sort of tackle that. Each practice has got their own policy, but we are working with them to improve that because it is in thousands. So we need to make sure that those missed opportunity is maximised really across the year. So that will be taken forward next year.
Yeah, and just in terms of some of our priority areas thank you, Ewan. So some of the priority areas that we have got from a Leicestershire perspective, we know that we've got some specific challenges around delivering additionality in Oadby and Wigston. So you'll have noticed in the paper where we talk about same-day access, some of the work that we've done over the last 12 months around how we increase and improve same-day access across our patch, and the equity around that as well means that what we are putting in as part of the new same-day access service that comes live from the 1st of April is an additional site into the Oadby and Wigston area as well. So that will take us up to about across Leicestershire, 35,000 appointments delivered. We've done some specific work around Charnwood, and as you will know, was part of the North West Leicestershire work that we're doing in the neighbourhood implementer site as well from a respiratory perspective. So there's lots of work going on. The other big piece of work that we'll be picking up as part of our 26-27 plan, working with general practice colleagues, will be around our frailty MDTs and integrated neighbourhood teams to support frailty. That is one of our biggest challenges. You know, when you think about the demographic of our population, particularly from a Leicestershire perspective, those are some of the areas that we know we've got some further work to do to support improvements in those areas as well. Before I move on to the Melton section, I just wanted to see if there were any specific questions.
Well, don't worry, I'll start off actually. So what is the ratio of GPs to patients? Do you have an ideal? Because I'm assuming you have an ideal of what stuff looks like, and that's questions already been asked by somebody, so I'll kick off with that, if you don't mind.
There isn't an ideal, so there isn't a benchmark that is set out nationally, but what we do have as part of our workforce numbers will be the GP to patient sort of ratio that will be worked out. So we'll know the numbers, and we can certainly share that back with yourselves for what we'll try to do is try and aggregate that up from a Leicestershire perspective, because what we do get back at the moment from the national team doesn't allow us to quite do that in the way that we would want to, but we can work on that in the background and provide that back. But there isn't a national benchmark. What we do use locally, it's not a GP to patient ratio, but it's almost to say what's the sort of benchmark around sort of appointments or contacts per 1,000, and we use a benchmark of about 75 per 1,000. So that is a benchmark locally we use. It's not contractual. Again, it's something that enables us to identify variation, and then to look and enable us to have conversations with practices where they are lower than that or where they are significantly higher than that.
Okay, thank you. Councillor King.
Thank you, Chair. Thank you for your report. I have to say I'm incredibly disappointed with it, because whilst it gives us a very interesting summary and you've added a little bit of detail to it, what I haven't got is the level of detail that I would expect to have in order to understand what's actually, giving me that summary. So so to be fair, some of the questions I'm now going to ask are because I haven't got the level of detail that I would have expected to see in order to scrutinise what's going on. So one of them, and the chair's just alluded to, well, what's the ratio of a GP to the number of patients? Now, the problem is, in all the great stuff you're telling us about, as an elected representative, residents come to me and say, I can't get an appointment at the doctor's, or they post loads of messages on Facebook or whatever it is, having a rant about things. Now, that's not an irregular occurrence. It happens regularly, routinely, and it doesn't matter what we say or do, not much seems to change. So it's incredibly frustrating. So what I'm concerned about is, you say that the number of appointments across LLR, and obviously the data is LLR, and we only deal with Leicestershire. We're not, currently, we're not about the city, and we're not about Rutland, not until the government decides what to do about LGR. So what I'm trying to understand is, you've got this LLR wide averages, but isn't there a danger in looking at averages that you're masking particular local access problems, particularly in the rural areas and market towns, which I represent one of those. Mine is the Gartree division, and other colleagues here. I don't want to get into the Melton debate now because that'll be for later. But you know, there is a real issue, I think, because a lot of Leicestershire is rural, and access to appointments is an issue that, as I said, residents raise. So I'm just wondering if this average is kind of hiding. But obviously, I haven't got the information to know if that is the case. I'm just obviously you're telling me. So I'm just wondering if you can explain that a bit, and also how do we know that if there are so basically, we've got appointments getting delivered, appointments attended, but how do we know if you're displacing demand in effect? So because someone can't get an appointment, they go down to the Royal, or they go to the urgent walk-in centre, or they go somewhere else, or they go to rugby, or they go to somewhere out of. How do we know we're not, because of the frustrations that residents are having by not being able to get same-day appointments? So that brings me very neatly to these same day access hubs. And I'm not against this, but isn't this what GPs should be doing in the first place? Offering same day access and same day appointments. And I note on the report, the detail you have given us, that 60% of appointments aren't same day already. So is this going to add real capacity on top of what's existing, or is this just hollowing out what we've already got? Is this just going to be instead of it being in the GPs, it's somewhere else? And that's the concern I've got. And you know, if demand exceeds supply, if I can put it like that, how are you going to deal with how are we going to cope with that? Are we just going to end up with raising expectations here and delivery down here somewhere? Because that's the concern. Because 35,000 appointments, it sounds a lot, but split that around Leicestershire, and that's not many on an individual location basis. So I'm just wondering, sorry, there's a lot in there, but these are really important questions because you're raising expectations. There's going to be same day access hubs, and people are going to lose the fact there's only going to be 35,000 appointments, whatever it is. Is that a day, or is that? Sorry, just clarify, if you could clarify those points. Sorry, Chair, that was a bit of a long sort of questions, but thank you.
Thank you. You can
No,
come back.
thank you. So there's a number of factors that the reasons for why the information is the way it is, because some of this comes back to us from the national teams, not necessarily often broken down in the way that would help us at a local basis, but we work with that and we work with our practices as well to try and understand that. So apologies if the information in here, this is the information that's available and is publicly available as well, which is what we have included into the report. In terms of your specific questions, so if I work backwards, because you know, the same day access one is at the forefront of my mind, that is for the whole year, so that's per annum. That is additionality, because what we have recognised with the work that we have done with general practice is that within the confines of the national contract, and I stress that it's a national contract, the GP contract is, it allows us, it doesn't give us the flexibility of enabling us to deliver what general practice needs to. So you could technically say within the national contract, it talks about providing same day access as well as you know, appointments in advance, etc. But it doesn't put a number on that in the national contract. It just kind of pulls it all together. So it feels quite woolly in terms of that. The work we have done locally is to say, we know what general practice can deliver as part of that 75 per thousand. What else is it that's needed over and above that, particularly going into the evenings and weekends? So currently core services run till 6:30. As part of the same day access, that will be to extending that Monday to Friday till 8:30 for same day access appointments, as well as the enhanced access appointments that general practice delivers. And then there will also be additionality of same day appointments on a weekend as well at a neighbourhood level, which is what we are doing as part of the same day access. So it is actual additionality over and above what is already delivered, and that's how we measure it. The other bit, this is absolutely linked into supporting our urgent care access across the board. So what we know is that especially those evenings and weekends where there isn't other alternatives, patients will follow with their feet to A&E departments. If you're sitting on the peripheries, they'll be going out towards George Eliot Notts, Corby, etc. If you're within sort of the peripheries of Leicester, it will be the Leicester Royal Infirmary. And as most people will know, we only have the one single ED department. So what we're trying to do here is about how we create other places people can be seen for those lower level of need that could be done and managed differently. And what we've done is link that in with our, like I say, the pharmacy first work as well, which is the work around the sort of 7 conditions that community pharmacies can see. And that is another sort of a whole load of capacity that's there. Now that capacity isn't set as this many thousand per population, etc. So we have got quite a significant amount of flexibility around how we utilise that and make sure we make the most out of that across Leicestershire. And obviously from a ICB perspective, we're also making sure we're doing that across Leicester and Rutland as well. So that's kind of where about the same day access. In terms of the appointments for Leicestershire, as I started off, what we have seen is it's sitting at about just under 0.5% increase up to October of this year on the appointments that were delivered the previous year. So we have seen an increase in the number of appointments delivered in totality across Leicestershire. And I absolutely take on board the issues that are faced by councillors from their constituents around, I can't get an appointment because we are fully aware of that. But there is obviously something around the balance around that in terms of there is a whole load of delivery that does happen. I think the experience and the actual delivery are the two things that we've got work still to do, and that will be ongoing to how we match that up. We'll never fully match that up and marry that up, but what we base it on is the numbers that we can see that are being delivered. And we know that there's some more work to do around the overall experience bit, which is the bit that you guys give us that feedback on, and we get feedback through the patient survey as well around what patients experience in terms of contacting their GP, seeing their GP practice, and being able to feel that they are getting their needs delivered. And that's work that's ongoing. We've got some really good practice that happens, and actually across Leicestershire there is some good consistency, but we know we've got some variation in that experience as well that we continue to work on.
Yeah,
so thanks for clarifying the thing about the same day access up. It's 35,000 per annum. Well, quick calculation, that's 96 extra a day split over 8 centres. That's 12 a day per centre. That doesn't sound an awful lot to me of increasing capacity.
It may not sound a lot, but it does make, in terms of the work that we have done, that still is significantly more than what we've got at the moment as well. So we have done a huge amount of work, and that is in what we've done there is we've got those plus the enhanced access appointments plus the pharmacy first. So when you pull all of that together, that gives us quite a significant more than what we've got currently.
All right, thank you, Sarah.
Yeah, I think it's Councillor King's point. It's how it's presented. It said, "Oh, look, 35,000. That's a lot." And I actually wrote on here, "What does that mean and look like for patients?" Yeah, exactly. I was a bit less generous than you, but more generous. Sorry, Mr. Toby, you wanted to come in briefly?
Yeah, if you wouldn't mind. Yeah, so good afternoon, colleagues. My name's Toby. I'm the Chief Executive of the Integrated Care Board. It's the first time I've been back in a county scrutiny committee for a number of years, but some of you will be familiar with me having worked in parts of LLR previously, and I've taken over from Caroline Javidic, who retired last summer, as many of you will be aware. I just wanted to take a step back. I'm conscious we're going to go into further detail, quite rightly and understandably, particularly a conversation about Melton, which we're keen to get into. But just if I may for a moment take a step back and look at Leicestershire County, and I mean county, not LLR, specifically. The two things I kind of think here are true at the same time, and that's what we're kind of grappling with this in this room. If you look at Leicestershire County from a general practice perspective, how it benchmarks against nationally and against much of the region, Leicestershire County is in a relatively good place in relation to general practice in terms of number of practices, in terms of access when we look at that, in terms of appointments per 1,000 population, and in terms of crucially quality as well, if you look at CQC and their overall assessments and ratings. So on the one hand, we've got a position which is factually the case that we have a relatively good position across Leicestershire County compared to many other parts of the country, and that's true. At the same time, it is also true that your inboxes and conversations with constituents and others will be full of discussions about, I can't get an appointment. I couldn't get an appointment when I wanted an appointment. I couldn't get an appointment to see the GP that I wanted. I was asked to see another member of clinical staff. And that is true at the same time. And it varies across different parts of the county. And we'll talk about some specific areas in terms of pressure in a moment. But I thought it was important just in terms of context here to acknowledge that from an overall relative perspective, Leicestershire County is in a relatively good place in terms of level of practice provision, quality of provision, and access across the county. The second point, and that's not to take away from anything at all from the conversations I know when I have discussions with MPs across the patch, when I have conversations with the members, a consistent dominant theme through that at the same time is the challenge that people have and feel they have accessing services when they need it, and they're both true at the same time. The second piece, Chair, if I may just briefly, I wanted to reference was the national policy position in relation to general practice, and you've talked, colleagues have talked here about some of the detail in terms of extending access, in terms of new clinical roles. There's effectively three strands to the kind of national policy view on how do we address both of those things being true at the same time. One of them is about additional roles, and this is about broadening the workforce in general practice. General practice today looks unrecognisable to general practice 30 years ago in terms of the mixture of roles that we have and other clinical and in some cases non-clinical staff where it's appropriate supporting our patients and our residents. So the first thread of this is about broader roles, and that is one of the reasons that crude measures like GPs per population actually is increasingly less meaningful given the wider skill mix that we've got, which is why we look very importantly at appointments per thousand population, because it gives you that broader view about the whole clinical and practice team. That's the first kind of big thread. The second big thread is about other providers being able to support, given the constraints that we know we have in terms of general practice, to provide care and support where that's appropriate. And areas like community pharmacy being one of those key strands, areas like NHS 111, where people are looking for simple telephone access. And then the third piece to this, in terms of the national position, and it relates to the same day access, is putting in place, albeit relatively small numbers when you drill it down, but important for those patients who might otherwise have felt the need to present at ED departments or to have contacted other health services, to differentiate between urgent same-day access for patients with simple conditions that may be presenting for the first time. It might be episodic, it might be someone that doesn't have ongoing other health conditions that could be seen by a clinician in a setting appropriately that doesn't have to be their core home GP practice. And those patients quite often are frail elderly population and others with multiple long-term conditions where more time spent with their own GP and their own practice is crucial. And that differentiation we will see more of from a national policy perspective to try and make sure people can get access when they need it, in some cases on the same day. In some cases, actually, what people want is an appointment in 2 weeks' time. And that's absolutely appropriate to be able to plan and manage those things in. So I just thought it was perhaps helpful to take a step back from, and we'll come back to detail, I'm sure, but from an overall county perspective, that position, which is a relatively good place at the same time as real challenge, which your citizens, which your residents will feel, and also acknowledging that policy position from a national perspective, which many of the initiatives that my colleagues here have described are very much about locally how we implement that direction. Thank you.
That's fair enough, but if we're not given information, I'll question it. Mr. Page.
That's a really good point, Chair. And actually, I'm going to come back to that. It's going to be something that you possibly don't want to hear. But I think you made a point about us being in blocks, whatever it was you used. We actually come here as representatives of divisions to Leicestershire County Council. And our job here is to scrutinise. And so to the extent that you've provided a macro view of the county, that's fine. But I expect to see data that actually looks at the significant towns and conurbations in the county to be able to do a complete analysis, a cross analysis of what it looks like for residents across our county. And I haven't seen that in these documents anywhere. So I would ask you to come back in future with however you manage to achieve it, push back up the line and try and get the data, because actually until you do, we're not able to do the job that you're asking, that we're expected to do. And I think I'm seeing lots of heads nodding around here. So I think it's critical that you do that. I've got 3 questions too, Chair. On the DNA statistics, that's quite simply staggering that between last year or the previous year and this year, there's a doubling of the DNA numbers. And I just want to ask you to to explain that a bit? And is it anything to do with the fact that 36% of patients are waiting between 8 and 21 days for their appointment, and therefore, as Councillor King says, going elsewhere, or perhaps they're forgetting, or perhaps they're getting over what it was that was important to them? We need a little bit more analysis behind that to understand it. The second one is, are the kind of working hours of GPs, a lot of them electing to go part-time, quality of life reasons, whatever, actually impacting on our ability to provide the full number of GP sessions that are required for practices? Is that making it more complex? And the third question is this. I don't quite understand the term about the term about patients, the number of additional patients seen when you talk about GP sessions saved. What actually is that? Does that mean then that the sessions saved means that there are more hours for GPs to see patients that come through the GP surgery, or what else are they doing in that time? And so if patients are being seen elsewhere by other strands within the health sector, what actually is happening through the throughput of the GP surgery if you're actually making theoretical sessions saved? If you could explain that, please, I'd be appreciative.
Thank you. If I can take the DNA question, if that's all right, thank you. Absolutely happy to come back with more analysis on that, because that is an ongoing program. The last 3 months of discussion that we've had with practices, the 90% of people that are DNing are those who are booking the appointments on the day, not those who are booking it in advance. So those who are booking in advance seems to be managing the appointments well, but those that are booking it on the day, that's where the challenges and probably more work needs to be done. So we are working with practices to sort of ensure how do we support those patients who've booked appointments in the morning and are not turning up in the afternoon. There must be a reason, and it's understanding what those reasons are. It will vary from one area to another. So in terms of supporting the patient and helping them understand that that's a missed opportunity for another patient, as well as wasting clinical resource, for example. So I think we're working on that and taking lots of learning from national team as well. But in terms of the detail, absolutely can provide that. Hopefully by the end of March, we'll have a bit more data and analysis on how it's progressing. Thank you. Yes, beg your pardon. Sorry, in terms of the GP session saved, that's how we measure in terms of what it looks like from a clinical saving GP session save perspective. They're not sitting there. They absolutely are providing other appointments as well. But it's just to demonstrate that had it not been, if this had not been in place, that's the number of hours that would have been wasted. I think that's what it is, and not being being made available to the public. So, for example, any appointments that they are sessions that are saving from GP perspective, they are still working, but then the access is quicker for those patients. That's what it is, because otherwise it'd have been delayed. I think that's what it is overall.
Sorry, Chair, just on that one then, are we able to see what the patient throughput then is, in which case related to those hours saved?
We can absolutely look at that data, no problem. Yeah, thank you.
Are you happy? Yeah, you asked 3 though.
Yeah, there was a second question about the working hours, the part-time working hours of GPs, and I would actually like a comment to the statement I made at the beginning as well.
So in terms of your comment on the part-time GPs, without having speaking to practices forensically, looking at that, because obviously each practice will set themselves up in specific ways, dependent on their workforce, how many part-time GPs they have, how many they usually do it on sessions. So that's how they'll work out the clinic times and the rotas with regards to that. So we can certainly get some examples of that from practices and share that back, so that colleagues and members around the table can get an idea in terms of how practices will pull that together. That is, I can't comment on whether there's more part-time GPs than there have been previously. We don't get that information in that way. So that is something that I can't comment on. So I can't answer that question, I'm afraid, to say that there's been more part-time GPs or less part-time GPs. What we get is a sort of overall, this is how many GPs there are, and a sort of whole-time equivalent of that. But what we don't get is an understanding or a breakdown of how many of those are part-time and how many of those are working full-time, for example. That's not that level of information that we receive. In terms of your overall comment and the breakdown of data by towns, we will look into that. I mean, one of the things that is always difficult is how do we break this down in a way that maintains a level of understanding, but also means that we don't drill something down too much that becomes patient identifiable. And often what happens, like I said, the information is aggregated up and then it comes back down to ourselves from the centre. Some of the things we could look at is data by primary care network, but it has got limitations on that because, again, that will not necessarily completely marry up with the sort of towns and districts that we have got because of the way general practice sort of the primary care network membership is not necessarily completely geographically based. Broadly in Leicestershire it is, but we know we've got some areas where we've got some, slight different variations to that in terms of how some of those memberships have sort of, it's a bit of a legacy in terms of what we've got from sort of years of how, practices work with one another, for example. So we could look at that and we could see what we can provide at a primary care network level. So that may give more context at the level that you are seeking, which then helps to understand, because I understand where you are coming from in terms of when you're looking at Leicestershire and I'm delivering numbers on a population. If you look at aggregated over 400,000 population, it's very difficult to try and understand that. This is what it looks like, for example, for Charnwood, or this is what it looks like for Hinckley and Bosworth. What we can do is look at what we can provide from a primary care network. So we can do that post-meeting as a bit of a post-meeting note to see what we can provide.
Bearing in mind, we look at things on a school by school level on occasion. That doesn't identify individual pupils, and I thought a GP by GP is very unlikely to identify individual patients, to be quite honest. Mr. Mayor.
Cheers. Thank you very much, and thank you very much, Yasmin and Mira, for your presentation. I think it's a very useful report to read. I agree with some of the comments made that some of the details is probably lacking, but maybe that's our expectation of what we would think would be in the report. But however, there are lots of positives, and as you said, Toby, GP care in 30 years ago, even 10 years ago, is different to what it is now, and it's been a long meeting already, item, so I'll just go straight to my point. But I just want to raise one thing, and that's to say, actually, the number of appointments are increasing, and everything on that you're showing us and presenting to us is increasing. In my personal experience, when I've rang the GPs in the last 6 months, I've always got an on-the-day appointment, and I haven't had any issues at all. And that's not to say that other people haven't had issues, but my experience has been in my practice that having a big practice makes sense, because then you might not see the same doctors, but you have access to that care, and I think that's most important. And when I've rang our care via 101 or all the others, I've been triaged to the right and appropriate settings, and I haven't faulted that at all. And also, it's just the way things are moving. And this is my question: is we give and I didn't know this, but 40% is on the day appointments, and that means everything else isn't on the day appointments. So is people's frustrations is because we are limiting it to 40%, or is that just how it falls? And if we increase the amount of appointment available on the day, would then people's frustrations evaporate, let's say?
So to put that into context around what general practice offers, the 60% is to enable them to really deal with patients with multimorbidity, long-term conditions, for who, having planned appointments and being seen in a planned way is better because it gives better continuity of care and enables more time to be spent with those patients as well. And that's why there's this balance to be had. Hence the reason why we've put in some of that. I know it sounds very small at 12 appointments and what have you, but it's small but can make quite a significant difference in terms of just increasing that number of same day appointments across the board, but also saying actually there's a whole raft of other things that you can also access on the day. So community pharmacy can be accessed on the day. Pharmacy First is there. General practice, if you ring your GP surgery, if they think actually, do you know what, for your condition, you can go to see your community pharmacy, they will refer and book you into your community pharmacy, and then you'll just go straight there rather than having to go to your GP practice. And that is an on-the-day appointment. Doesn't necessarily get recorded as an on-the-day appointment for GP, but it is a same-day appointment. So when you look at that in its totality and kind of step back, there is much more that is available that supports that on the day. I think there's some more work, like I said, that we've got to do around how we support more proactively around frailty and frailty management and some of those longer term conditions, and that preventative bit, which is really important and probably more important in the grand scheme of things, and particularly for the population from a Leicestershire demographic perspective, that becomes really important. As if we really tackle that and manage that better, that does inadvertently reduce some of that demand that happens on the day as well, because that's just firefighting, whereas the other stuff is really trying to proactively get to the sort of to the nub of the problems and issues that our population faces.
Mrs. Knight.
I'd like to build on a question that Mr. Page raised regarding DNA's missed appointments. It doubled last year, just under 290,000 missed appointments, equating, you've listed 139 hours of lost clinical time. That has a cost. So each missed appointment has an associated cost. I'd like to know what that is. And therefore the fluffy words in the next paragraph 36, if you have an appointment that you cannot attend, you must cancel it. And if you need to cancel an appointment, it's really easy to do so. It's a bit wet, isn't it? I think we need to be a bit stronger. If you miss an appointment, like if you've got a private dental practice, you get charged. So come on, I think we need to be a bit stronger here. There's a lot of people saying they can't get appointments. There's a lot of wasted appointments. I think we just need to be a bit more strong. Thank you.
Thank you, and I absolutely agree around the strong messages going out to our patient and residents to say missed opportunity for other people if they are sort of DNAing. So unfortunately, in terms of how individual GP practices manage their sort of DNA policy will be different. So our role is to ensure that we are providing with them with tools and techniques in terms of how they can address and manage it based on working with their PPG groups, for example, their residents and whatnot. But I think the message from our end through our comms and engagement has been very strong around making sure that everybody sort of utilizes their appointment if they're not going to be using their appointments to cancel in due course. So one of the thing, but on the flip, we do hear the fact that cancelling the appointment sometimes is not made easier as well, and therefore working with practices say you need to have mechanisms in place, processes in place where people want to cancel the appointment, they can do so, and that doesn't become a hindrance. In terms of the costs, that's something we can absolutely look at. Yeah, thank you.
Says Leicester Royal are very good at texting you to remind you have an appointment, and again and again and again, but that's by the by. Mr. Poland.
Thank you, and thank you for the presentation. I think Matt and Toby said the services from years ago have changed significantly in terms of the facilities available at GP surgeries. I think can't remember offhand the last time I actually saw a doctor at my GP surgery. It's usually a practice nurse or whatever, and that's fine because they sort what I want, and that's fine. So I mean that as a positive thing, if anything. And the other thing that sort of that's becoming an increasing factor in healthcare is sort of digital services and accessing things online, phoning 111, doing the NHS app and so forth. And again, I'm a big proponent of using technology where it can improve things in healthcare. If that can get the result we want, then again, very much in favour of that. The slight concern I do have, though, and sort of the basis of my question, I think was touched on by a colleague earlier on in terms of displaced services. My wife has had 2 occasions to use it 111 or NHS app in the last year or so. One was on Monday this week. First time, she had shortness of breath or something. It was a pretty relatively minor thing, but she needed to get some advice on it after it had been there a couple of weeks. Phoned the GP, couldn't get through. So she phoned 111. We went through the big long question, who then said, "You need an ambulance." And we're like, "I'm sure you don't need an ambulance, but what do we know?" So you go with the advice you received. The ambulance turned up pretty quickly, and surely she didn't. They were really good with her, but she blatantly didn't need an ambulance. Again, she's had a few issues that won't go into in detail, but suffice to say, she needed to see a GP this week on Monday. She again, now I think we discussed in another place, we could only do it online to access it, the surgery. So there's no option to turn up or phone it. It's only online. So again, couldn't get through. Again, went to NHS, this time using the app, did her thing with it, and it said she needed to go to A&E. Now, again, fact is she didn't need to go to A&E, but unlike this time, she just went, "That's rubbish, I'm not going to A&E." So she did it again, and finally, after all that, got a GP to review it, and she ended up getting sent a prescription. She's got her stuff now, that's fine. My point is, twice she's used NHS services that have said once to send me that ambulance and the second time to go to A&E. And first time we got the ambulance, and as I say, they were great, but she didn't need it. And the second time, had she just gone with what it said, she'd have ended up at the Royal when she didn't need it. So I wondered how many people are being displaced and going, getting ambulances and going to Royal that frankly don't need it. And that's just, as I say, from my own experience.
And Mr. Poland, I've picked your issue up with the practice. I will be chasing that up because they shouldn't be. You should be able to phone for an on-the-day acute episode, and it shouldn't be going through the online consultation. So we have picked that up as well with that practice, and we'll continue to do that. It's obviously clear that that hasn't been sorted out, but I will make sure that we can sort that issue out. With regards to 111, they follow a national algorithm. So it goes through that process with the health advisors asking they don't always get it right. As you can see, we feed that back up, so we will be feeding that up. We know that there are regular call reviews to look at what's been missed and the missed opportunities. There isn't much that can be done around the national algorithm because it has safety features fixed into it, so that should there have been somebody that did need an ambulance that then wasn't given an ambulance, that's the sort of worst case scenario. But we will feed that back up. We continue to do that with 111, and we work quite closely with 111 and the ambulance service around what we could do to improve that. One of the things I can absolutely talk about in terms of that sort of displacement of activity, one thing we've looked at in terms of this year, we have broadly stayed within our plans in terms of those number of patients that are attending ED. So from a Leicestershire perspective, that we haven't seen any significant increases. We know that October, for example, of this year, when we had the early peak of flu, we saw real pressure on services across the board. But what we can certainly say over the winter period, I know the 2 weeks post-Christmas are always really busy, but what we haven't seen is more significant peaks around those things. So we haven't seen as significant a displacement as we have previous years because of a number of things that we have done. But absolutely take on board that for the 100 patients that go into the right places, there will always be the 1 or 2, and that's the bit that we continue to work on to make sure that we are absolutely doing everything we can do to make sure patients are seen in the right place at the right time as well.
Councillor King did another go.
Well,
one person after you, then we're going to move on to Mel.
okay, thanks, Chair.
I'd just like to say, Toby, welcome back to Scrutiny. Make a politician out of you one day, I'm sure, because you're very smooth with your answer, but I'd expect nothing less with a man of your infinite experience. But what I wanted to say, Chair, is priority one in this report says to reduce unwarranted variation, improving access for patients. And I think everyone around this table would agree that's what we want to see. We absolutely want to see that. Our concern is that we're not getting there quickly enough. And, you know, that I think that's what you're hearing. But in paragraph 27, I think you kind of outline what the problem is. Patients get confused. They don't understand. Now, Yasmin, you mentioned earlier you can ring your GPs and get a same day appointment. You can't. Not at the GP practice I'm at, because they send messages out telling you can't ring them up. You mustn't ring them up. And if you do, they won't give you an appointment. You must fill in the app, unless you're in the non-online category, digitally not enabled, in which case, yes, you can do that. Or you can go in and make an appointment. So everyone's confused, and I'll be polite about it because we're on a public recording, but everyone is confused. Patients are confused. And ultimately, patients are taxpayers. And we're all footing the bill for this. And it's costing us an awful lot of money. And the government's decided to give you, the NHS, a lot more money, of our money, to pay for this. And that's concerning all of us, because taxes, that takes a lot of people's hard-earned cash. So that's basically what this is about. And, you know, and so that's the concern I've got. So just coming back to the digital issue, what I wanted to understand, and I think I did raise this previously, what is being done now? All the practices, I understand, have all got different online consultation. My practice I'm at, South Leicestershire, they use something called Rapid Healthcare, which you have to fill in an online form and they send it off and it gets triaged, or you get a message saying I have an appointment. Other people are using, as you understand, are using a WhatsApp system. And a colleague of mine told me recently that it wasn't terribly effective, or they didn't think it was. So what is being done? What is the ICB doing to evaluate these different systems that practices have chosen to implement, and how effective or otherwise they are? Because the feedback I'm getting is some of them work better than others, and patient experience for some of them is just increase the level of frustration and genuine annoyance that they can't actually get access to treatment when they need to, and actually it's causing them a lot of problems with that. So I'm just wondering what we're doing about that. And also picking up your point, Yasmin, about this telephone, what is being done to straighten out practices to make sure that they're all offering the same offer, if that is what they're supposed to be doing, instead of one doing one thing and the next door one doing something else, and everyone's then going, okay, well, I don't understand what I'm supposed to do. So that's what I wanted to ask. Thank you.
So in terms of the digital elements, they are broadly using two platforms. There's Rapid Health, which we have got a small amount of practices that are using and piloting that and testing that out. So we will start to, I think, 26, 27, get the sort of full evaluation of that to look at whether that is a better system. The other one is AccuRx. I'm not sure about the WhatsApp-based system, but AccuRx is on on the national framework. So there's no practice that's not using something that's not on the national framework. And broadly, those are the two platforms that are being used across Leicestershire, Leicester and Rutland from our GP practices. So we've got fairly sort of standard consistency on that. Where we've got differentiation, and this has been because of the way in which I think the rollout of the mandate that came in the national contract came on in October, has been a differentiation of how our practices have interpreted that mandate. So where it has been very clear, and we have sent very clear messages to our practices, and as and when we are every month at the moment out to practices, sort of checking their websites and also making sure that their website's got the same information. For example, where we have been made aware of anything that's out with that, we've been going back to those practices specifically to say, that is incorrect. That is not what you're supposed to be using online consultation for. Here's what you're supposed to be doing. I've had personal experience of it as a patient myself. So I have, we have been raising this and we'll continue to. We know that there's always a settling in period. When something like this happens with our practices, we've got 125 practices that we're dealing with and making sure that they all do the same thing at the same time, which is not always necessarily the case. But we are working on that continuously to make it really clear. The mandate is that they should be making online consultation available for routine, so that's non-urgent, and admin tasks. So if you've got somewhere where you want a repeat prescription, for example, that can be put through through online consultation or through the NHS app, which would be much easier for those that can do that. If you require a blood test, for example, that can be done through the online consultation tool, or if it's something you're not quite sure about, so you put that through. If you think you've got a referral but you've not heard anything, you can put that through the online consultation tool, and the practice then triages that and gets the most appropriate person to contact the patient back. For anything that is episodic or urgent on the day, a patient should still be able to contact the practice by phone. And that is very clear within the contract, and that's the message that we have sent back out to all of our practices. So I just wanted to sort of give that clarification back to yourselves as well, because obviously that's a message important from giving back to your constituents as well. Anything where that isn't happening, please do let your constituents know to contact the practice, or at least make that known to the practice, or make it known to the ICB through its general inquiries, and we will pick that up with practices as well.
I think my view that we should nationalise all the GP practices is demonstrated by the variation amongst them, but we'll draw a veil over that. Toby wanted to come in.
Thank you, Chair. I shall try and be a little bit less polished. Two comments and an ask, if I may. And actually, the first comment is where Councillor Hill's just gone in terms of the variation point. In a sense, the range of questions that we've had and people's experiences of their own GP practices kind of illustrates an awful lot of the challenge here, which is we've got a large number of independent practices operating that we contract with and commission with, and it's on us to work on how we level up. But there are times when you will have, all of us as patients, really, really different experiences, and that's not an excuse. It's simply a statement of the reality, the variation that we've got, and we've got to figure out how we spot those things, whether or not we need to be, and try and level up into that. The second comment I'd make, there's been a bit of a running theme, I think, through bits of the conversation so far, and I suspect we might get to more of this from a Melton perspective around detailed data and what I'll call mapping, being able to see stuff visually in terms of let's look at Leicestershire and understand what's on. There are things that we can provide and feed into that. I don't know where we went slightly wrong in expectations of what was on some of the paperwork today, but if we can be clear coming out of this and perhaps work with officer colleagues, more than happy to look at how we can put some material together in that space. And it may be like that from a public health perspective, in particular in some of the data and mapping stuff, that we can do things that can just portray that a bit more visually, so it's easier to get the picture across the whole of the county. And then my last point, my third point, which is an ask actually, and back to Councillor Knight's comments around DNAs and the did not attend kind of numbers. I suspect most of our residents would be genuinely surprised at the level of people not attending, and particularly those people who've booked an appointment on the same day. When you go back to the conversations we have with our friends and our relatives and neighbours about you can't get an appointment to see a GP, and then you look at the number of people who've been able to access an appointment that day, and then subsequently, now I'm sure there's complex reasons for that. People have managed to access support somewhere else, the day took over, they didn't manage to book it. But if there's anything, my ask to you guys would be through your various social media channels in particular, that we can do to help reiterate the importance of that. Under a nationally contracted model, we can't and won't be fining people for not attending, but I understand the sentiment behind it, which is being a bit clearer with people to really encourage appropriate use. And if you can't make it and you've secured an appointment, let somebody know, or do your absolute best to, so that we can try and make sure that that is utilised.
That's something that, from your perspective, I'm sure really needs a deep understanding of why, particularly the same day ones, and find out from people, why didn't you turn up? Because there may be a whole range of reasons. It probably vary by practice. So we won't go there because we'll be here all afternoon discussing that. Mrs. Barber.
Thanks, Chair. Fiona Barber from Health Watch Leicester and Leicestershire. we've heard a lot today from around the table, lots of different experiences from people in attempting to contact surgeries for appointments. And to be fair, that's the theme that comes to Health Watch. Over the years, it's been a consistent theme, and we've had a number of discussions with ICB colleagues over the years about how that can be improved. We've worked through the GP survey with colleagues to try and understand it and to try and come up with, to support the ICB to come up with ideas on how to improve it. And I think listening, you touched on the CQC inspections, and of course, having one outstanding practice and one requiring improvement and the rest in the middle is pretty decent. And as Toby pointed out, you know, nationally, Leicestershire is thought of as a reasonably okay system, GP wise. But that doesn't give a huge amount of comfort to individual patients when they're trying to contact the surgery to get something done. So we need to balance the reality of the national and regional approach down with what that matters for each, or how that impacts on each individual patient and their particular lives. The CQC stuff is interesting, but a lot of it is really out of date. A lot of it is pre-COVID. So whilst CQC have just been through their own reorganisation, I think now that they have a general practice section, division up and running, they will relaunch their primary care inspections, which all of us can contribute to through the website, through our practices and so on. And that will help to achieve the sort of consistency that I think the ICB colleagues have alluded to in terms of trying to level up some of the surgery stuff. I know that ICB colleagues do keep records of variations between practices, and that is really useful information for something like a scrutiny committee to understand the variations in, for example, why one practice has a lot of people turning up at A&E or using 111 as opposed to being dealt with at the practice. Whether patients from particular practice are comfortable using the app or the online systems for those practices. And that is probably more useful than I can't get through on the telephone. It gives us a greater understanding as a scrutiny committee about what sort of work's going on and what might be needed, where the focus might be. So from a Health Watch perspective, the experience is very valid. It's still valid. It's still being discussed. And what people say to us that despite all the approaches, what they value more than anything is consistency. So if I'm asked to complete an online form, why isn't my neighbour who goes to the other practice in the same location doing the same? What's the difference? What impact does that have on me as a patient? So there is some information there around the variations that scrutiny committees could use to actually have a better quality conversation about what are the issues and how counsellors can help in going forward. So I think, Madam Chair, there are issues there that scrutiny could pick up in the future. Thanks.
Okay. Thank you for that. Let's talk about Melton Mowbray then.
Okay, so we'll pick up Melton particularly. As you will see in the paper in the second section of the page, which talks about Melton Mowbray, the infographic that's in there, that is the data that we've looked at Melton, Syston and Vale primary care network. So that is bringing together Melton, the practice Melton, plus the practices in Syston and Vale together, and that's kind of then the totality of the numbers provided. What I did ask the team to have a look at very quickly with regards to Melton specifically, and speaking to Melton practice, was to understand what the total number of the number of appointments that were delivered by Melton practice itself, and I think we've got the number of that, isn't there? Yeah. 28,000, yeah. Sorry, so what they did from April to October 2025, was 28,084 appointments were delivered to patients during that period for Melton. If I look, when we compare that with the same period for 2024, that's a 6.3 increase compared to that previous year. If you look at the infographic, it will show you that the appointment rate per 1,000 patients is 566, which is more than the national average as well, compared when you compare that to the national average. Like I say, there's no benchmarks around this. So what we're doing is just looking at what's nationally delivered, and then is it over and above that. Whether that's good or bad is something that, you know, can be interpreted in different ways. But that is kind of what's being delivered from a Melton perspective. We looked to see whether there were any specific things that we picked up in terms of from a quality or variation perspective for the practice. There isn't anything that specifically pulls up in terms of the information that we have with regards to the practice. And like Fiona has said, the CQC rating is from back in March 2020. So, you know, it says good, but obviously that was more than 5 years ago. So you take it as it's read in terms of that, and like I say, we're waiting for those to be redone in the coming sort of year or 2 years maybe, in terms of when they'll actually get done. The other bits that I wanted to sort of pick up is that so Melton, the practice Melton is it has got a registered list size. It is a large size of 35,905 patients. I think one of the things that the Commission asked us is that the largest practice in LLR? That is the largest practice in LLR. The next largest practice is Market Harborough, which has 29,000 patients registered to Market Harborough practice. So that's a single. I think one of the questions was asked, you know, is it the single group practice? That is a single group practice. When we look at it nationally, we've got 63 practices that are larger or similar to size as that. What I don't have the detail on is whether they are multi-site practices or single group practices. That's something we would have to go away and look at to see whether that is the case. The likelihood is obviously it will be a mixture of those, but generally one of the things we find, especially if we look at sort of those county type practices, they usually are single group practices. Large registered practices, multi-site, usually sit in urban areas, but we will double check that and provide that information back post scrutiny today. The other elements that I think in terms of understanding what we have looked at as has been raised is that one of the things we were asked previously, and I know that this has been with previous counterparts, around looking at addressing whether there is a need for a second practice. Now, I think that's something that has locally been expressed quite strongly by local residents and constituents to say that a second practice for Melton is something that is needed. There's been work that's happened with ICB colleagues and partners to look at that, to scope that, to see whether that is something that is feasible or viable. There were options that were explored with Melton Borough Council with regards to that, and neither of those were seen as financially viable. Even with the developer contributions, I think of about circa £1 million in terms of either co-location or a new build, a co-location in a new build, or a repurpose of accommodation to provide a clinical space for a second surgery within that, and that was something that came back through that route. There was a decision that was undertaken in August 2025 by the ICB to pause the current consideration of a new GP practice, but it remains committed to continuing to work with Melton Borough Council to explore further options. The other bit that was also done is to continue to work with Latham House as well, to pick up particular some of the challenges that Latham House has had in terms of ensuring that they have got the workforce that is required to deliver. And I know that there's been work going on actively by Latham House practice to increase. They are increased they've got 2 further GPs that they have recruited through the ARRS work in Q3, and they continue with their sort of recruitment of nursing staff and other AHP staff as well. I know that the practice has also been looking at further sort of clinical space at I think it's Sherrard Street, but can correct me if I'm wrong. We're waiting for the practice to confirm where those conversations have been had and what the sort of final outcome of that is. I think we tried to contact the practice today. We weren't able to get through to them to speak to them about it, but we will continue to do that piece of work with them. That is something that they're doing off their own back. So
the irony of you not being able to get hold of them just sort of rings with the people. I apologise.
Okay. So that's where we're at. I just wanted to give some of the reasons that were within the rationale, and I'll let Toby come in on some of the detail around that as well. So the reasons for the pause have been around the ICB doesn't receive capital funding to develop new practices itself, so we don't receive any specific capital funding for new premises through the NHS. The published data that we've got in the as part of the NHS data that we have from 2020 to August 2025 show only a 3.19% increase in patient registrations at the current Melton practice. So we haven't seen any significant registrations at the practice, but that's the data that we have access to. Currently, the evidence basic according to local and national published data in terms of appointment, that Melton should be prioritised over other areas across LLR for investment in additional primary care service provision, which is the bit that we've not found anything that gives us evidence over and above what we have already got. And like I say, the evidence at the moment doesn't state that there is something that's of a more priority compared to other areas within Leicestershire. And the ICBs are going through that process, as you can imagine, around our reduction in management costs as well. So the capacity to do the further work at this point in time is paused whilst we complete that management of change process. Toby, did you want to come in on?
Perhaps keener to hear some of the comments and questions and perhaps respond back in afterwards. Good full overview.
Okay, thank you. Mr. Innes.
Thank you, Chair. I'm just reflecting on the fact that we've got 4 county councillors from Melton sitting in the room. I'm wondering why Melton, the councillors from Melton have felt the need to raise this as a particular concern. And the reason I'm wondering about that is because I can't see any data that says whether Melton is any better or any worse, or where we've been, where we're going. And I take Mr. King's point that he's made, and I'm not going to go over it again, but I have got no clue whether we're in a good position or a bad position. So what I'm going to say to you is this. I have residents coming to me saying, I am worried about my husband because he can't get an appointment. If he's got cancer, how do we know he's been told to come back in 3-4 weeks. My wife, my partner was, she had some real issues last year. We had to go to A&E twice because we couldn't get appointments. The question I have is, and perhaps the direct question, 3 years ago or 4 years ago, and I'll leave it to Mr. Orson to probably give the detail on this, there was a need recognised for a practice. We're now sitting 4 years later with residents complaining,
can't get blood tests, or the blood tests are, you've got to wait 6 weeks, but your follow-up appointment from a consultant or whatever is 4 weeks hence. It just, there is chaos in Melton, and that's why 4 of us are sitting here. And I just wanted to make that point that there's something not right in Melton, and you don't know why, and we don't know why, because we're not seeing the data. And therefore, how do we address it? I don't know how you're even going to pinpoint how you address it if you don't have the specific data. You tell us that we're above average and in the UK, and you know, we've got good provision, but I've got residents who are worried about their health, and they come to me, they phone me, they email me, we get it on Facebook. So there's something not right. Thank you, Chair.
Is anybody going to come back on that, or shall I move to the next speaker?
Sure, I'll come in at that point. I didn't know whether any of your colleagues wanted to come in before responding. I mean, firstly, thank you, and I appreciate all 4 of you attending today and being here. It says a lot about the kind of priority to that and how important it is for your constituents. And we recognise what you describe in terms of the difficulties and challenges that patients experience in terms of access. As I outlined at the outset in the conversation, we've got 2 things that are often true at the same time, and that continues to be the case as we look at it here. So I'm being very open with you in this conversation and saying, from the data that we see, and I think some of it is, with respect, shared within the paperwork in terms of access, in terms of number of appointments, from a clinical perspective within the local area, within the primary care network area, Latham House doesn't stand out and look particularly remarkable at all in terms of level of access, in terms of number of appointments available. In fact, benchmarked slightly ahead of the county position and certainly ahead of the national position. And the size of the practice itself is not automatically or necessarily a trigger or a cause for concern. We have a number of large practices across the country in other areas. As some of you are aware, I'm, in addition to being the Chief Executive here in LLR, I'm also the Chief Executive for Northamptonshire. We have a practice that's 46,000 in terms of one of our large practices in Northamptonshire. I'm not holding them up as a benchmark or a beacon of good practice, but the point I'm making, I suppose, is large practices are not necessarily of themselves something which leads to cause for concern. And actually, as one of your colleagues referenced earlier on, there are upsides to large practices in terms of ability to employ a broader skill mix, in terms of the range of services they're sometimes able to offer. We undoubtedly have an issue here in terms of the choice point. And I say that as a former resident of the Vale of Belvoir. I've got friends and others who are registered with Latham. And if you're in that local area, you've got one practice. And that tends to be the case where you've got market towns or villages that are served by a single area. So we've got 2 kind of issues that I can see from my perspective here. One, the issue from an access point of view. My observation would be, and I say it's an observation because I'm relatively recent stepping back into the county, but my observation would be that the practice has been listening to that. I appreciate that may not be perceived from a local perspective, but there are a number of things I'm aware the practice has been doing over recent months to attempt to respond to the issues in terms of access, both in terms of recruitment, in terms of premises and looking for alternatives locally, and also how they use their branch facility as well nearby. But I absolutely recognise that none of that yet feels like it's making the difference it does on the ground. And I think the third component we've got here is which I think you've touched on yet, but I know we have in previous correspondence, the housing kind of development piece in terms of population growth, in terms of the pressures that will put on an area in the future. The reason that the ICB in summer of last year took that decision to pause further work at this point in time is because none of the data or the metrics we're looking at would prioritise Melton above other areas across Leicestershire if we were looking to establish a new GP surgery. I'll come back to the if point in a moment, because there's something important for this committee to understand in terms of how such those arrangements might work. And that's the reason that we've taken that decision to pause at this point. That is not to say we're not continuing to work with the practice in order to encourage them to do everything they're able to improve the experience for people who are registered with that practice. And we would and continue to welcome feedback through this committee and through other forums in terms of people's experience of that, because we recognise it is genuinely difficult, and it's conversations I've had with the local MP for that area and others. In terms of the kind of what I'll describe as binary, second practice, not second practice kind of perspective. In terms of how GP practices are commissioned and are funded, they are funded on a per registered patient basis. So we fund our practices according to the number of patients that are registered with them. We don't therefore routinely see, either here or in other parts of the country, new practices being established from scratch. And for one simple reason, which is if you establish a new practice from scratch and you've got no patients registered with you, you don't have an income stream as an income fund to enable you to be able to provide a GP surgery. A GP surgery from scratch to be viable today in terms of current list size will probably be 1.2, 1.5 million in terms of taxpayers funding to enable them to be able to operate and establish. So there's a very significant difference between working from a responsible commissioner perspective with taxpayers funding around the way that practices are funding established, and seeking to work with existing practices in those areas to do everything they can to improve and address the concerns and issues that are there. So I hope, Chair, that in sense I'm not in any way wanting to be dismissive of the experience, which I know to be true, both from friends and others in that local area. But I see a practice that acknowledges that and is trying to do something to address those things. And from the data we see a set of benchmark data which wouldn't prioritise Melton above other areas from the county, even if we were in the arena of setting up new surgeries, which for those financial reasons I've outlined, that is not a strategy that we actively have across this area and frankly most of the country at the moment in terms of GP practice provision.
Mr. Lovegrove.
Thank you, Chair, and thank you for all the information. First one is a point is this information is about Melton and the borough of Melton. Yet the statistics include Syston in there. Syston is a lovely place, but why are Syston figures included in this discussion? We're talking about the Melton borough. If it's not broken, don't fix it. But for at least a generation, people are saying that Latham House is broken. It's no wonder no more people are signing up to join Latham House, because it feels like in Melton it's a sinking ship. And there may be some good numbers in there because their doctors are doing a good job against a very difficult situation. For generations, they said that Melton wouldn't get a ring road. It is opening this spring. For generations, they've been saying that Melton is going to get a second doctor's surgery. Let's hope it's not more generations down the line before that happens. But there's almost an expectation within Melton that the system they've got in Melton, with losing the maternity unit, and Melton residents have been crying out for a second surgery or more capacity within the town and the borough for a long while. It feels as if that they're having their backs turned on them because of the service they're getting at the moment. I'm lucky I live in the Vale, so I access Long Clawson, but I'm sure we have a lot of people from Melton registering in Long Clawson and the Stackyard because they know the picture and the service that they get from Latham House. So whether it's a second surgery in Melton or changing the capacity of Latham House, there is something which is not working. Thank you.
Toby.
So I think you kind of hit the nail on the head in terms of the capacity point. And I think that's something that we are keen and committed to continue to work with the practice, to work with the local council and with other members here in terms of how we take account particularly of that future housing growth point, which is just going to add further pressure onto a practice that is clearly strained and has been over recent years. The data point within the pack, I'm pretty sure it's primary care network level data that's been included, which is back to the point that my colleagues made earlier on, that the way that we cut quite a number of our things these days looks at primary care network groupings, and that's why Syston is included within that. But I'm more than happy for us separately to provide that level of data, because it does drop down. Certainly the appointments per thousand population drops to individual practice level. I'm saying that, I'm checking that I've got that right for Leicestershire as well.
Yes.
Yeah, okay. So we can provide that information down at practice level, which I think becomes more meaningful for the local conversation from a Melton perspective.
I've got Mr. Poland next.
Thank you very much. Again, a few of the points I was going to make have sort of been touched on already. The patient register at Latham House, as we know, is nearly 36,000. And with the Melton South Sustainable Neighbourhood proposal being built, which is another 3,000 houses or thereabouts, you know, even if we said 2 people per house, which I think would probably be a lower estimate, you're still then looking at, you know, without a new surgery, 42,000 patients at Latham House, which is obviously a very, very high number. So my question, got a few questions, if that's okay. In terms of a new practice in Melton Mowbray, I think you mentioned it was 1.2 to 1.5 million for a sustainable new surgery. What portion of that would be land purchase and building costs? And would there be any potential to work with developers developing south of Melton in order to get land as part, instead of, you know, as a sort of, instead of a section 106 or whatever, for them to effectively build a GP surgery, you know, instead of having a sort of traditional section 106. I know from conversations I've had with developers historically in different places, not in Melton, that they've said to me, what concerns have you got? I've gone GP surgeries, GP access, and they'll say, well, we'll build you a surgery. That's not the issue. Is the issue the minute you ask the ICB whether they'll do it, they'll say, no, I did, and they did. So this was years ago, by the way. This is not recently, and it wasn't in Melton. So I wonder whether that is something that could be looked at, as to whether actually we could say to the developer, would you be willing to build us, give us the land and build us a GP practice in lieu of 106? And as a sort of second part of that, how much money does the ICB currently have sort of in now from Melton Mowbray for GP surgeries from developments that have already been built that could potentially be put towards that? You mentioned about lack of patient choice. I think that, as you say, is a real issue. In Melton, if for whatever reason a patient either falls out with the practice or the practice removes someone from their list, there really is no plan B. I know that there is a far smaller surgeries up in the Vale, but that's, I believe, at capacity with no ability to expand. So that for me really is a concern for Melton residents, that, as I say, that they're sort of, you're stuck with where you are and there is no real alternative beyond travelling tens of miles to elsewhere, where of course surgery is already full as well. If you come over to my part of the world in Sizedon, again, we have the same sort of concerns in terms of people, capacity issues there. And sort of, thirdly, I do wonder, well, as part of the second part, if I can just finish the point as well on that, whether we have enough GPs at the surgery to deal with 36,000 people. Doing some research, it suggests perhaps that might be the case, based on the national average GPs. But ultimately, most people sort of want to try and get through to the surgery on the phone. Again, technology we talked about before is coming into this. That might help in due course, but most people still want to get through on the phone. I mentioned at the start, and I declared it, and I declare it again now, I work for the MP for Melton and Sizedon. With that hat on, I've had to try and get through to the surgery numerous times, and I've every single, without exception, one exception, I've had your experience. They have not been able to get through. So I do wonder whether you have a bottleneck at that point with sort of that many people trying to get through enough lines. So again, that's a point to sort of consider, because obviously you ultimately need to be able to make contact with the surgery. And last question I've got really is, you mentioned that Melton doesn't have a demonstrable need for GP surgeries compared to elsewhere in Leicestershire. Just out of interest, where else in Leicestershire does have a greater demonstrable need for GP services than Melton?
I'll take the first couple of parts of that. I'll then come to you as in terms of the kind of other priority areas point. So the funding point, the numbers that I referenced and the kind of developer bit, the numbers I was making reference to were the revenue cost on an annual basis running a GP practice. So not capital cost. The people you spoke to a number of years are entirely right. Capital costs of development are rarely the rate limiting step in terms of development of GP and funding of GP facilities. That's not that it doesn't cost material money to build new facilities, but there are routes through that. It's also a market that has a established third-party developer route where there are a number of private companies that will work with practices in order to invest and develop. And we've got a number of very good facilities across parts of the county, which are already provided through those kind of routes. So that's not to say that capital isn't important, because clearly capital is necessary where we're talking about estates and premises developments, but it is not in general the rate limiting factor as to whether we are able to progress and develop with things. The issue here is the revenue consequences of that, and that's why colleagues you will have spoken to in previous years would have said we had a solution in terms of a third-party developer route, but we had a conversation with the Primary Care Trust or the CCG or the ICB as it is these days, and they said no. And the reason that they said no is because they don't have an allocated budget for a set of patients that don't exist. Our funding model in terms of how ICBs and predecessor bodies are funded is on a per population basis, and we get a per capita level of funding for our population. And GP practices that start off, as I referenced earlier on, without patients don't have an established list and therefore don't have the ability in terms of generating that funding. So the constraint we have is if we were to establish 1, 3, 5 or 7 new GP surgeries, bringing it, personalising it, I wouldn't get any increase in my budget at a local level to enable me to fund that. So if I'm already funding existing GP surgeries to the level of allocation that government sees fit to allocate into the NHS and through to ourselves, and I recognise the comment made earlier on around relative levels of growth into that compared to other sectors, that does not come with additional resource that enables us to do that. So it's a choices point you then get into at a local level to say, if we were to put another 1.5 million into a new surgery somewhere in a climate where actually the ICB in this part of my cluster is currently running on a deficit position, that's something which is not funded. So it's the revenue element of it rather than the capital. And that's not to say capital is always straightforward. 106 funding is tremendous because it often helps us with a bit of a boost. 106 rarely covers the full cost of new build developments, but it can be a really useful addition either in part to something or back to the conversation, which I think was really helpful around, is this actually a discussion about additional capacity? 106 funding can be really useful in extending, expanding, altering existing premises to enable us to increase clinical space and therefore provide more capacity, but without an entirely new surgery being the answer to that. I hope that helps in part on the kind of funding piece. Jasmine, would you like to pick up on the point about if not Melton, then where, I think was the question.
At this point in time, but in terms of from a new practice or, establishing a new practice, there isn't anywhere in Leicester, Leicestershire or Rutland that we would be prioritising because in terms of what we have got at the moment is sufficient. What we do have is constraints around estates that are quite significant in certain areas, particularly in some of our more urban areas where we have got practices that are still operating out of terraced properties and semi-detached properties, for example, that are really our priorities. We get very small amounts of capital funding that is made available. We use our estate strategy with working with our general practice colleagues and partners to identify those areas that we invest that into, just from a thing this perspective in terms of the investment that we've got going into 26-27. We've got about 9 of the 16 priority practices that are from the county that we're investing some money into to support them to either expand their current premises or make refurbishments to their current premises that enables them to deliver the services that they need to. I think there's a real important point around infrastructure capacity. So the point that is touched on quite a lot, and we'll pick this up, and I'll pick this up particularly with the team to look at what else we can do with regards to supporting some of those larger practices, and maybe a conversation will definitely pick up, I think, more detailed one, Mayor, around Latham House's infrastructure that enables them to things like answer telephone calls. Have they got, I know they've got cloud-based telephony, but if you've not, if their receptionists are trying to operate from the most smallest of rooms, in a small space, it becomes really difficult to do that for a large practice of that size. So that is something we'll definitely pick up to see what those things that we can support them with to make those improvements that can make quite a big difference, which is less about the clinical bit, because I know they are absolutely working on that, but more on the admin and infrastructure side that might actually help and support them with improving some of those connectivity elements that could help improve patient experience, particularly when you've got patients trying to call in, trying to make appointments. If the first hurdle always is, if you can't make that contact, that's where it kind of falls down on. And if we can improve that with Melton, we can certainly do that with Latham House. We can work on that.
Yeah, briefly.
Thank you. Thank you very much for those answers, clarifying my understanding. In terms of the revenue then for a new surgery, how many patients, if this is the right way of looking at it, how many patients would 1.2 to 1.5 million represent? So literally, how many patients would need to be on the new surgeries books before we hit a point where it's a going concern effectively? And from just to clarify what you're saying, my understanding is that if we created that, there would obviously be a corresponding reduction in Latham House's finances accordingly. Again, if you could clarify that, if that is correct or not correct. Thank you very much again for all of the answers, but in terms of checking in terms of the ability to contact, again, that's probably one of the most frustrating things for patients doing the 8 o'clock dash and having to be on to work and take kids to school and all of that business. If it's possible, it would be good if we could sort of have an update on that in a period of time in the future that's reasonable to this committee and probably to the Melton councillors as well that are affected, just to sort of see what the outcome of that is in a reasonable period of time, whatever that would be.
The question I think in there was the question around funding and number of patients, etc. So the number I've referenced, the kind of 1.2, 1.5, is a very broad number. It depends what you commission, what's included within that. That was based on some work that was done last year, looking at around 5,000 this size sort of practice. So if you're looking at that sort of size, you've sort of 5,000 to 6,000 registered patients, you'd be in that sort of ballpark. Now, quite clearly, if you look at the size of Melton and you were to look at a number of patients, you could quite easily see significant people choosing to switch. That's a patient choice issue. The funding follows the patients, and therefore if you were to establish something as an alternative, you have a material difference to an existing facility, which is an important provision for that area and is existing and is funded. And so you kind of get into the equation here, of course, as well about choices in all of that. The only time in my career that we've actively, I'm going back 15, 16 years now, that we've actually commissioned from scratch GP surgeries was under a nationally funded programme to establish new surgeries from scratch, and it tapered funding up over the first few years linked into list size. So it's not that it can't be done, but it's linking it into triggers that would justify that level of public investment in something entirely new and additive. And I was simply being open with our colleagues here from the local area that at the moment I don't see that in the numbers. That's not to say we might not reach that sort of trigger point in subsequent years, particularly linked into the housing piece. But my commitment to this room today and together with colleagues here is it's been a really helpful discussion. There's a lot of points we can pick up and take back with Latham and pick up with the practice. I'm actually keen to go out and visit personally in order to talk with partners there to see what we can do in the short run to continue to help them address some of the issues that have been raised here.
Can you just indulge my brain cell, because I know a bit about legal firms. If some sort of 3 or 4 GPs got together and said, we want to set up a practice, we'll do it, we want to be NHS, we'll pay for the building and take the first year's overhead, would you commission them?
Not automatically, no. There's no automatic right of entitlement for a practice to establish from scratch and to enter. They would need a contract with us to be able to do that under national contractual rules.
It's a nice little monopoly, isn't it? Councillor King.
Thanks, Chair. Just on that last point, I think what would be useful to know is it Latham House public owned or is it actually owned by the practice? But just coming back to a couple of points, So first of all, according to the Royal College of GPs, the average number of patients per GP has increased from 2016 from 1938 to 2236, according to their report in December. I'm only going on what's on their website. So again, going back to what we said earlier on in this meeting, we've got a lack of information basically about what the average number of patients is per practice. And this kind of also applies to this Latham House scenario. It's a very big practice. It's the biggest in the county, as you've stated. And so therefore, with being the largest in the county in a single building, and I understand the rationale for that, because going back a long time ago, there was a rationale for bring it all in one house and it'll be super duper, all singing, all dancing, strings and whistles and all the rest of it, and patients will get a top quality service. Now the problem is there are clearly, for listening to what colleagues from Melton are saying, I've had no experience of it, so I can only go on what they're telling me. It's not. So there are some issues, and that's something that needs to be looked into. And you've said you're going to, so that's great. But then equally, it comes back to one of the founding principles of the NHS, as far as I'm aware, still is patient choice. And the patient, we have a choice. We are entitled to make a choice of who we choose to get clinical services from, or not, as the case may be. And in this particular locality, there is no choice. You've got one practice you can go to, and yes, there might be other alternative providers through community pharmacy and the minor injuries clinic and all that sort of stuff, but that's at the periphery. But core service is provided by one practice. Now, if for a variety of reasons you fall out with that practice, or your confidence is dented as the patient because you're not happy with some aspect of it, then what are the options to you? There doesn't seem there are many. There are many other options to you apart from long trips to other practices, and that's a concern. But if over time, and I'm sure we're all aware of this, if over time the perception, and perception is 9/10 of this, if the perception of residents is they're not happy with something, they tend to vote with their feet, and they don't come along to the practice and say, oh, by the way, we're not registering you, we're going off to so and so. They just go and do it. And therefore, it's kind of hard to look at this and know, well, actually, is that happening or not? I've got no data in front of me that tells me that. I mean, the 3.19 increase in registrations, that's probably in line with the population growth in the Melton area over the last few years. But as you've said yourself, you've got 6,000 houses, and I know my Melton colleagues will know this better than I, 6,000 homes that are supposed to be being delivered by 2036. So you've got this huge growth. Now, when we at other places take planning decisions, and I have my other hat on for a moment, a member of a local planning authority, one of the biggest concerns that gets raised in the planning process is availability of future availability of GP appointments, access to medical care. It gets raised time and time and time again. And yet, as an LPA, we have got zero control over what goes on. That all falls to parts of the NHS to come up with that. So I was a bit sort of concerned to see in the report the mention of Section 106 developer contributions. I had to reread this because it does say with private and other public contributions, but also listening to you, Toby, Section 106 is not going to provide a total solution. It's only going to provide the uplift. It's only going to provide a proportion. Now, what happens with a lot of Section 106 contributions, or some contributions that get provided for the NHS, is, I mean, strange things like new floors or new consulting rooms or things like that get added on to practices. Not necessarily patients not really sure whether they get any benefit out of that, but that's what's requested, and it's been deemed to be SIL compliant and things like that. So presumably it gets spent. But one of the concerns here is that, you know, when we go through the planning process elsewhere, this is one of the number one issues that gets raised with us. Not the only one, there are others as well, but it is one of the top three issues that gets raised, I think. And, you know, here we are, and you're saying, oh, well, we can't do it because we haven't got any money, basically. There isn't enough and we can't find a solution. So what I want to try and understand is, it does say that you'll come back if you can before 2027 to have another look at it. But what are the triggers that would need to change for you, for the ICB to look at this again? Obviously, I've got no sight over what the other priorities are because I haven't got a list of them. So I don't know where the other primary care priorities are and what, you know, whether they're doable or not. You know, obviously that you guys know that. But what are the triggers that would need to change for you to kind of relook at this before, you know, a year over a year's time, or is that unlikely to happen? Thank you.
Thank you. A lot in that. A number of points to pick up, and then I'll come to your specific question at the end. On the 106 piece, I just want to clarify in terms of understanding here, to be clear that we do get and understand how 106 funding works. I said that personally, having trained professionally as a town planner and started life working in local authority. 106 funding is hugely helpful in terms of helping to generate income from a capital perspective to enable us to do things. At this point in time, looking across Leicestershire, across LLR and across the county, we have somewhere in the order of 22 million at the moment, which is 106 funding contributions secured at varying stages of multiple different schemes across the county. They'll range from very small developments to very large developments. Some of them will be linked into trigger points. They all have their own conditions that are linked into them. Some of them are for very specified purposes in terms of health provision. Some of them are very broad and general. As a principle, and perhaps worth noting going forwards, we from an NHS commissioning point of view are very committed to working with local authority planning teams where there are new developments coming through, particularly when we've got some of the larger sustainable urban extensions and things of that nature where we've got very significant house building coming through, because transport, education, housing, in my experience, are the three biggies that kind of 106 funding contributions tend to be concentrated into. And there's something about our role in that, and there's something about local authority roles in negotiating those arrangements with developers. Now, for those existing schemes that we've got across the county, they're all at various stages of development. We know what they are, we know where they are, we've got those logged, we hold a tracker of that data, and we work with planning teams. And some of it is entirely appropriate to invest in things like new flooring or improved entrances. We all want spaces which are appropriate for modern healthcare. That means meeting control of infection standards and so on, and where that level of investment can help those things to make sure we've got clinic spaces that are appropriate, then that's a good thing from my perspective. We find a smaller number of those schemes which will be much more material levels of funding, which would enable us to do something of a much bigger scale. But still, in general, it tends to be contribution to, rather than the ability to fund in its entirety a new facility or a new service. To your question at the end around, I think in essence, when would we review, or what would it take for this to be different? Our commitment here, and having listened to the conversation, there's a very consistent theme coming through, particularly from this side of the room, the feedback around access, telephones, booking systems, appointment systems, triage systems. And I think as you've described some of that as infrastructure, I'll describe it as the kind of front end bit of practices in terms of how patients get access and experience that. There is clearly something here that we need to continue to work with the practice and with others around. I've heard less in this room and in other rooms about quality of care and service provision once people make their way. And that's not to Chair to want to open up an entirely different debate here, but certainly what I've seen to date and what I've seen come through are various routes where we get feedback in terms of patient experience and issues has been much less so in terms of the actual core provision, which kind of correlates for me at one level with that level of appointments that we know are available, the level of clinical staff, the skill mix we've got within that practice and their facilities as well. So the trigger point for me in this conversation will be if we reached a point in the future where we get to a stage that the practice is not able and committed to continue working with us to address those things. If we reached a stage in the future where we've got housing growth that reaches a stage that we've actually got a tipping point, if potentially helpfully we secure further 106 contributions off the back of those things, they start to create a different case potentially around that. But I'm just being really open here, and the reason we set a timescale and the ICB in its pause decision last year through until early 2027 is that I can't see those things materially changing as we go across the course of this year, whilst we continue to work with the practice themselves to try and address those issues, which they've openly acknowledged and recognised there is more that they can and should and want to do, which is why you've seen, I think, some of that more public-facing material that they've put into the media recently around their recruitment, around premises and so on. So I guess my ask would be let's work with the practice and support them to address the issues they acknowledge, and let's also just keep an eye and a watch on what happens in terms of the wider population piece. Thank you.
Mrs. Knight.
Looking at paragraph 75, the data is from Melton Syston and the Vale. I personally and I'm sure my other colleagues would like it, splitting up Melston, Syston and the Vale, because the appointment type, 60% across the three, it could be 80% in Syston, 40% in Melton. So I would like to see that separated view. I would also like to see missed appointments in the three of those as well, just so we can digest individually what's Melton, what's Syston and what's the Vale. You're also saying from an external view, Melton, Syston and the Vale are no different to any other large surgery, and you don't see anything visibly different. Therefore, my conclusion is, from your perspective externally, there's nothing different to how another large surgery works. It says to me there's something internal to that surgery, whether it be mismanagement, bad processes, I don't know. You say you're working with the surgery to work it out. I think if we got the dissected information for each of the Melton, Syston and the Vale, and then with your understanding of what you think's possibly going wrong in the surgery, I think we can't wait a year, be on hold for a year. We need to do something now. We certainly can't wait for 2 years for another surgery that might turn up, might not turn up. We need to do something now. So help us to help ourselves, please, because there's something definitely wrong in Melton, Syston and the Vale, please.
So we'll look at trying to get that PCN information, the primary care network information, split by practice. So obviously we've got a number of practices, so that'll be Long Course and the 2 practices in Syston plus Latham House as well. So we'll try and get that split so you can see that information split across the four or five, I think, practices that make up the PCN, the primary care network. We'll get that information plus the DNAs as well. We'll do that post this meeting. We'll try and get that done in the next fortnight. I'm just looking to my colleague to make sure we can get that actioned to work that through. And then the other bit around the practice, we are meeting with them. We've tried arranging that as well, and we can get an update in the next sort of month around that date, around that meeting, and what we've agreed with them with regards to the next steps, particularly around some of the things that have been raised today, which, as you have described, Councillor Knight, as the internal elements that we need to work through, and the what I class as infrastructure, the bits around those bits around, you know, the admin capacity, all of those things that would make a material difference around the experience for patients. We'll pick that up, and obviously, as I said, we are expecting them to update us on the additional site bit as well, which they are working on securing too.
So we just want to come in quickly.
It's super quick. It's just a question to the local members for the Melton area. Do you have, or have you had, kind of regular contact or conversations directly with the practice? And would you welcome if we were to offer to convene? I'm just conscious we're having a very detailed conversation about a particular practice in this forum. I'd be very happy if you would welcome it to convene a roundtable conversation with the practice to just take stock of where we are and explore some of these issues with them. Because from my experience, actually sitting down and having a conversation direct is often the most productive way of moving these things. I appreciate local MPs and others have been in more direct dialogue. So it was a really question to the room here, Chair.
Mr. Innes wanted to make, I think, very similar actually.
I think I was actually going to say, if you're going to be having meetings, give me a call, give us a call. I'm very happy to join. And in answer to your question, yes, a month after I was elected in May, I was starting to get the undercurrent of an issue, and I actually had a Teams call with them and said, look, what's going on? And a lot of it was on communication, actually. A lot of it, they were saying, we need to get our message out to the residents. Can you help? And I said, of course, yeah. But, you know, they need to do a lot of self-help as well. Thanks, Joe.
Councillor Olsen, I feel like you're a donkey out of Animal Farm, that you've seen it all.
Yeah, well, thank you very much, Sarah. Chair, Chair. Toby, I think I remember you from Safer Community Strategy Board. Did you ever go attend those meetings? I can remember somewhere along the line. I've never been on health and scrutiny, but you know what is a bit like my two colleagues on the left have already said. What really comes home to me is how Melton only has 4 councillors, and yet here we are, all 4 of us. This is the first time in over 20 years I've ever known that happen for Melton Mowbray at any scrutiny committee. So it goes to show the pressure that's on us, that's coming from our residents. But before I go any further, I should declare that I'm a member of Melton Borough Council. I was leader of Melton Borough Council from 2017 to 2023, and I'm not a patient of Latham House. I'm a patient of Long Clawson, which I'm very happy with, and I think the new system they've adopted works brilliantly for me. A lot of what Councillor Ornett has said in his question and the answers given, it saves me having to go through that. I support everything that effectively Brian, Andrew and Kerry have said down the road, down at the end of the line, and we're working as a team on this one. I represent what's called Melton Wolds, 40 odd villages, and yet I would imagine half of my residents possibly attend Latham House, mainly because Astleby, the hill, the village and the valley and surrounding villages go to Latham House. And so, as you can imagine, that's a lot of people, 5,000 plus in my area who attend Latham House. And the frustrations they've got are being echoed again by my colleague and also by James up there as well, especially on the telephone access. Where I am frustrated, I do feel let down actually by the ICB, because in 2019 we had a district election and my side of the camp put a leaflet out saying our primary reason was to campaign for a second GP surgery in Melton. Melton still has 15 seats on the district council. And our side took 13, if I remember correct. I might be slightly wrong, but we took 13. It was unprecedented, that was. And it went against the general swing everywhere else. We did start having discussions with ICB, and it went on for quite a few years. And they were quite, they took place about every 3 months, very informative. And in 2022, I did then agree with the previous chief executive. I think Andy Williams was his name. Yeah, I remember that name because it's my mother's favourite crooner, so how could I forget? And we both agreed, and I seem to remember it was online, it was a virtual handshake on delivery of a second GP surgery for Melton. That was in 2022. In 2023, the election cycle comes around again, and sadly, we didn't win. We won the most seats, actually, but the opposition clubbed together and took over, and a new leader who spoke this afternoon took over. And as I understand it, he has continued to meet the ICB, or has done up to now anyway. A considerable amount of Melton Borough Council money was spent on consultants looking at Parkside, how that could building be adapted. I understand it was northward of £35,000, which is huge money for Melton Borough Council. What I'm not so sure on, they did then look at Phoenix House. I think and only think they spent some money there as well with consultants. I believe also on the Parkside, ICB helped fund the consultants as well. I think it was a 50-50 arrangement, but you might know more. Both buildings were ruled out. To be fair, I could have told them that. I'm not a builder myself, but anyone could see you could not convert either building to a doctor's surgery, especially Phoenix House. Parkside, just totally the wrong shape when it comes to the modern lift systems and bringing in the power supplies needed for those scanning things you will have nowadays, which I see at the System practice. But even so, a huge amount of public money was spent. And then the plug is pulled, effectively, until at least next year, where you'll consider it again. Likelihood nothing will happen next year. I don't know that, but that's my prediction by listening to yourself on the figures. So, I personally feel massively let down. I spent 3 years of discussions with the ICB, had a handshake. In my world, the farming world, you have a handshake. That's a deal, mate. You got a deal. Okay, it might be on the back of a fag packet in the old-fashioned way, but it's still a deal. I feel let down, and I can certainly say the residents of Melton Wolds, of Melton Beaver, of Melton East and Melton West feel massively let down too. The whole of Melton. We seem to be losing out on everything. We got a lovely shiny new road, thanks to Leicestershire County Council. Absolutely amazing road, which will be opening soon. But we just seem to be losing everything else. And this just seems to be another, it is a knock to Melton. And the confidence, as you've heard, is just leaving Melton. It's a real shame. But this was promised by me, to me. Handshake took place, and it's not going to happen, is it? Let's be fair. Thank you.
So thank you for that, and I genuinely understand the frustration. I know there's been a long history to these conversations over recent years. I've not clearly been involved in those discussions previously and some of those decision points. But I understand why, if you have been, and many of you in this room have been, why that feels frustrating. Those of us in public office in the roles that we occupy have a duty, I believe, to come to meetings like this from a scrutiny perspective and be straight and open and transparent. And that's what I'm being today. I appreciate that many of you wish I might have come along today and said something different or other than that, but I have to be open with this room in terms of where we are, the information that we see, and how that looks at this point in time. And I can't, in all honesty, comment on some of the decision points and perspectives that might have been taken previously. I'd like to come back, if I may, to Councillor Knight's comments at this end of the table about not waiting till 2027, which effectively is where you kind of ended, I think, your previous words. I don't want us to wait till 2027 to continue to work with the practice to address the issues that are there, but I'm not going to sit here and either give false assurance or comfort or pretend that there's something coming through here in the short run that is different than we've indicated at the moment. That is kind of where we are at, and it is based on that information and that kind of intelligence from a local perspective. But I recognise that there is further work that needs to be done with the practice. There is work that the practice needs to do to continue to help themselves, and I see them doing that and making a start to that, but it is not sufficient, and we need to work with them further in that space. And there are some things undoubtedly that you can help us to do to understand how some of that works at a local level. The population and the housing growth bit is potentially the long run thing here that changes some of the equation on this, and that's a bit which actually some of the local authority planning teams might have a better insight in terms of what's coming through. I did meet with the chief executive of the local council shortly before Christmas on this and other matters, and it's something that I've asked for continued input to help us understand that future pipeline in terms of housing development and potential sites that might come forwards.
Joe, not to come back.
Yeah, following the publication in 2019 of our manifesto, and then, as I said, I think it was 13 out of 15 councillors in Melton Town we took, largely due to that work that we committed to do with the ICB to deliver a second doctor surgery. About 2 months after the elections, we were invited by Latham House, a number of us were, and we went down, and yes, it was informative. So I know Andrew's indicated he would be willing to go, and I'm sure Brian would be, and I'm sure Kerry would be too as well, because we can relay the frustrations that our residents have, and there are so many. They are genuinely so many, and I suspect the Melton Times will be reporting on this meeting. It's going to be interesting to see what reaction that we get from the residents of Melton when it appears on Facebook as well. And let's just hope some of the comments you made, people understand. But there's a massive frustration in Melton on this, what I see as a promise that wasn't delivered. Thank you.
Grove.
Thank you, Chair. Just a very quick one. As well as a meeting with Latham House, it might be good to have some discussions with Melton Borough Council on the housing building plans which are in place, so you have an idea. I think if you wait till houses are up and then look to get a second surgery, it doesn't match time-wise. But to give you an indication that the ring road has gone in, I joked about 2 or 3 generations, but it's important that you get an understanding that housing will follow that, and the pressure, whether you sort out sort of administration things at Latham House, the pressure on Latham House will only increase. Thank you, Chair.
Let's be honest, local plans are up to what, 2036 are we at now, if not beyond? So we know where the houses and when. Sorry, is this on this point?
Yeah.
Just briefly then, James, I've got two more.
Yeah, just to reinforce that point, I mean, we talked about, if we're talking about sort of 5,000 people being sort of a potential goer, and 3,000 of them as a minimum, I would suggest, are coming from the development to the south alone. I think there is a real potential opportunity there. You know, 3,000 of you there already, aren't they? If you see what I mean, or potentially there in place. So just to reinforce the point, I think now would be a really good time to sort of to have those conversations with Melton, and ensure the second surgery comes as part of the local plan or the wider plan down the line.
Mrs. Barber, you waiting?
Yeah, thanks, Chair. A couple of points. First of all, historically, over the last year, a number of people have contacted Health Watch from the Melton area to talk about the experience that they've had through Latham House. I think we had 62 inquiries, 49 of those were sadly negative, mostly around the old chestnut of being able to access appointments when people felt that they actually needed it. Having said that, looking forward, Melton, like many other boroughs and districts, has a significant development housing-wise coming down the line. I can recall conversations in 2019 around the development of the Ring Road and the associated estates either side. And it is imperative, I think, that those organisations commissioning and providing services are aware of the timescales and how long it actually takes to get these things in place. And from a Health Watch perspective, we would be really concerned that patients should get the best possible experience, and to do that, they need services in place. And given the timescales and where we're at now with a pause, potentially the needs of patients may not be met as those developments come online. And that gives pause for thought, I think, for all those providers involved in this. And you have to also give thought to what's happening with the NHS. You have to look at the 10-year plan and the elements there, and the drive at the moment to shift services out into the community, the development of neighbourhood models of care, and perhaps ask ourselves as a scrutiny committee whether those issues, the 10-year plan and the shift around in how services might be developed, whether those present an opportunity to ICBs to actually work with local communities, such as Melton, to develop different ways of providing those services, because quite clearly the traditional method of primary care GP practice in situ has its issues and challenges. And if the ICB can think a little bit more innovatively, perhaps, listen to the communities that it's working with and discuss those ideas and how best to bring them in, whilst that's not a complete answer to having a second GP practice in Melton, it can help in terms of actually providing services that are needed by patients as they or as the area is developed in terms of housing. And that is where I think Health Watch would recommend consideration be given by councillors representing communities and the ICB, not just to think about developments and second practices, but also to look at how could services be developed and delivered in different ways in the area that would actually help meet the needs of those potential patients, rather than just say it's too difficult, we're pausing, because at the end of the day that really doesn't benefit anybody, and we need, I think, to make sure that patients should get the best possible service they can for the money that's available, and if we can do that in a different fashion, so be it. Thanks, Chair.
Joe, you just wanted to make a comment on that.
It's not a comment on that actually, but it's a comment, a very small comment, and it's a positive comment as well, by the way. I was saying just before this meeting to someone in this room, and she can't remember who, I did have a conversation with one of our good friends as well just before us coming, who almost certainly will be, if not watching it, will be watching it tonight. That we both feel that it's only a feeling, but we're not, there isn't quite so much angst about Latham House at this moment in time. Yeah, maybe they are beginning to turn the corner, maybe. I don't know. It's just a feel I got by. I'm not getting quite so many questions about it. Neither is the guy I'm talking to, because his village, most people go to Latham House. It's only a feel, but it might be the start of a turn, and fingers crossed it is a turn. But boy, they've got to go another few degrees yet. Thank you very much.
Well, fingers crossed indeed. Mr. Page, your last comment on this issue.
Okay, thank you very much. I'm somewhat at a loss here, really, in some respects, listening to the councillors from Melton. There seems to be an absolute disconnect between the quantitative data that you've got and the qualitative information coming back to you. These issues aren't new. They've been going on for some time. And I'm keen to understand how this gap has been allowed to continue with so much expression from the community and from councillors in this time, with so many expressing dissatisfaction. So my question really is, what kind of scrutiny do you place practices under? And how do you manage the qualitative information on the face of a lot of statistics that you do have at your disposal? And what are you going to do about, and what are you doing when you realize that there is a gap? What sanctions and tools do you have in place to improve the outcomes? That's the first point. The second point, I don't need an answer on, but it's merely a comment, which is I also am a district councillor at Harborough. And one of the issues that I think we're all facing, is this point around infrastructure being in place before we commit to building. And sadly, it isn't happening, but you're a consultee in the process. And I've often seen your comments come back about we might need a doctor here or two doctors or whatever it might be. I think your language needs to be fundamentally stronger than that, in that you need to be raising significant concerns about the quality of care that under existing arrangements, unless if this application was to proceed, there would be a distinct reduction in the level of quality of care for residents who already live there, in addition to those who will be moving into the new houses, unless, of course, there is actually a proper process for making sure that infrastructure comes first before the houses. So that's the only point I'd make, to use your position as a consultee to advocate far more strongly for residents. So take it back to the first question, if you wouldn't mind, please.
I might just briefly comment on the second, to agree actually, and then come to Yasmin on the first. There is more that we can and should do in terms of our engagement process from a planning perspective, and have been doing in some patches. In my other area that I kind of lead in Northamptonshire, we have in the last 12 months secured the largest health contribution into a 106 scheme of 5 million that I've ever seen in terms of our work. And that's been done through us investing in professional planning advice and support to help us advocate through that process. That is a very, very large development. We're in sustainable urban extension territory, but it goes to show that if we get behind and advocate and make the case, and if local authority partners and planning teams work with us constructively, as many do, and I'm sure most do here, then there are things that we can do to land and secure some of that resource that will help us to be able to get ahead of the infrastructure curve, not be responding on the back of it. It can be done when we get behind it in that way. At the moment, I'm interested in how we unlock the 22 that we've got already in train in different parts of Leicestershire, but there's more we can do with those other things coming through. Yasmin, on that first point now, in terms of how the quality oversight, monitoring and sanctions piece.
So it will always be the case that you have your quantitative data and your qualitative information that comes through. A lot of that comes through patient experience surveys, but also in terms of complaints, etc., that come through. Our quality oversight team sort of pulls that together, and we do have a dashboard that tells us in terms of those practices that are, you know, sort of flashing up on both sides, and on what do we need to do there. Or we could have what we've got here, where, you know, the quantitative data looks a certain way, the qualitative data doesn't quite marry up, and we will still look at that. In terms of sanctions, the national contract construct has limitations, and doesn't give you lots of things in terms of what you could, you know, financial sanctions, etc., are not things that are quite possible through the national contract. But what we tend to do is work more on an improvement side of things. So rather than sanctions, because all that does is just not often addresses the problems, because you're penalising, you end up in an entrenched situation. Actually, what we find is dialogue and conversation around improvement areas and what we could do to support that improvement with practices is much more helpful. That has been the case around Latham House. I know we joked about, you know, me not being able to get a hold of them this morning, but we have been meeting with them, and the teams have been meeting with them on a regular basis to look at and address some of their issues. And some of that was around things like their workforce challenges, which a lot of practices do have. But when you're in a certain area, and you have some limitations around some of that, there's some further work to do. They have engaged with us on that, and that takes time as well, getting them to trust us to work with us, and to engage with them. We're starting to see the improvements as a result of that engagement piece. There's some further work to do with them, and the other conversation is around things like how they answer the telephones, what they're doing around navigation, and how they're navigating their patients through the system. All of those things, although they may sound really straightforward, does take time. Now, one of the things I would always put into context when we talk about general practice, and I know they're independent providers, and putting all of that to one side, they are generally very small outfits of, you know, of organizations. You know, they sit with, you know, a small team, and sometimes what they often can't see is that they have to grow that, but where they're going to grow that to, all of those things that we work with them, rather than trying to penalize them. What we do is we work on a basis of improvement, identify the areas of improvement, and then work with them over the course of time to try and get those improvements in. That has been happening. We've got further work to do, like I say, with the practice in terms of the here and now issues, because of all the conversations we've had. Those are things that will happen in the next 2, 3, 4, 5, 6 years. There are some things that need to happen now, that needs to change for the population of Melton, and we need to do those things that improve, almost incrementally improve some of that experience for our population in Melton, which is a priority, and we will continue to work with Latham House to do that. I think the point that Fiona's picked up around the opportunities around neighbourhoods and the 10-year plan, I think there's something there as well. So we'll definitely pick that up and look at what we could do to bring some of that together. So I know we have got a health and wellbeing plan for Melton. So is there opportunities in that could help us think about things in a bit of a different way than the way we have been, around how we use our integrated neighbourhood teams, for example, some of the frailty work that we want to do. If we were doing that differently, and bringing in other partners and organisations to support that, would that mean that we could be doing something much more better for the population in Melton, that doesn't necessarily just completely rely on just the practice to deliver that, but actually a network of partners to be able to deliver that intervention?
Okay, well, thank you to Toby, Maya and Yasmin. I suggest we have a quick 10-minute break and restart at 5:22 and then romp through our final items. Thank you, everyone. Okay, then, everybody, we shall commence on the basis that we want to go home. It's getting late. Mike, talk to us about your budget, which is all ring fenced and stuff, so less exciting than some other people's.
Yeah, okay, I'll probably sort of divvy it up a little bit as well. So yeah, purpose of the paper is to go through, well, it's not about my budget, it's about the medium-term financial strategy as it relates to public health. The point being, public health is different because we are financed by a ring-fenced public health grant that can only be spent on public health activity, which comes to us from the Department of Health and Social Care. So I could have done a really short paper which just said, how does public health relate to the MTFS and vice versa? And God, it doesn't. Thanks a lot. Goodbye. But there is one or two bits in the MTFS that we do need to cover. And I thought it was worthwhile just setting out the nature of the budget for public health and where we're at. So I'm joined by Adrian Allen, my Assistant Director of Public Health, and online is Sam Barrett, our Finance Business Partner. So it's not just me. And I'll call on them for any massive detail or questions I can answer, which would probably be any question. So first bit, paragraphs 3 through to 5, just set out the overall position of the council as it relates to the MTFS, which again I'm sure members will be familiar with from council meetings and the cabinet paper on next year's budget that was considered at December cabinet. Kind of park that for a bit because then we'll come on to the public health funding bit, which is set out in paragraphs 6 to 11. So as I said, funded by a specific grant. There are a few things that have changed this year in terms of that grant. Normally, we present the budget paper without quite knowing what the grant's going to be because the HSC never tell us the grant until kind of, well, normally till about February, and sometimes we've known it go into the start of the financial year before we knew what a budget was for that year. This year, they did manage to release details of the budget on 17th of December, or what our allocation is. And for the first time that I can think of in about 10 years, we've had a multi-year settlement. So we've got 3-year allocations, albeit that years 2 and 3 are indicative allocations to give us some certainty about what is coming through. The other thing they've done is for a few years now, we have been receiving the core public health grant, but then there's been top-up supplementary grants specifically for work on drugs and alcohol treatment and smoking work as well, which they're listed in the bullet points that's in paragraph 7. And they've gone a kind of consolidated the grant and rolled them all into the public health grant. So we've got one funding grant, which kind of covers everything. Other changes that they've made, so as you can see in paragraph 8, the overall effect is if our grant last year was sort of just under 31 million quid, this year it looks like a fairly significant increase up to 33 million quid, but much of that is to do with rolling in these supplementary grants into the pot. We planned, when myself and Adrian sat down and did the budget planning for 26, 27, we had to have a punt at what we thought was going to be, and we planned for 2% as a fairly prudent sort of guesstimate, if you like, about where we thought the increase would land. If you take out the stuff that's been folded into the grant and just kind of did a like-for-like basis, we weren't far off because it has basically given us approximately a 1.9% increase on the grant from 25-26 to 26-27, which is good news for us, good bit of planning. The other bit that's new is if it's confusing enough to have a ring-fenced public health grant that can only be spent on public health activity and all the grant conditions that go alongside it, they've now specified ring fences within a ring fence. So there are set amounts that we need to spend on drugs and alcohol treatment, prevention and recovery year on year within the grant, and also on smoking cessation. So we've got ring fences within a ring fence and sort of tapered increases in spending on those two core areas of public health activity. The overall financial analysis would be those ring fences within a ring fence come with year on year quite substantial increases. So the effect being, I know the person that wrote paragraph 10 because it's me, so that should be 10% year on year increase in those ring fence grants. Essentially, if you look at the grant in the whole increase in the grant year on year over the course of years 1 to 2 and 2 to 3, half of that whole increase needs to be spent on either substance misuse or smoking cessation. So those two bits of the budget get sort of 10% increases, if you like, in those areas year on year.
That leaves the rest of the budget only going up by, I think it's less than 2% from memory. I've kind of lost the figures, but it's it's a 2.4%, 26, 27 to 27, 28, but then only 1.6% between 27 and 28. So by definition, it's one of those ones that is, we're currently working on a plan which we have to submit to the centre on what we'll invest our substance misuse growth money in, if you like, and that needs to be signed off by the centre. But actually the rest of stuff outside of smoking and substance misuse, particularly in the 27 to 28 to 29 year, is going to be fairly tight because we're only looking at kind of 2% and then a 1.6% increase. So from a services, described as service transformation, but from a grant point of view, 3-year allocations are welcome. It gives us some certainty. Folding in those grants are welcome, but then we're just teasing out exactly our specific plans around substance misuse and recognising that it could have been a lot worse, but things will be tight in years 2 and 3 of that. I'll sort of probably pause after paragraph 15, I think we said, isn't it? That then takes us on to the proposed revenue budget. The first budget is the link in with the MTFS. So there is an element of the public health grant that we do spend outside of the department, and that's on things in the rest of the authority which kind of meet the threshold for the public health grant conditions. So there's a lot of things that the council does, pretty much everything that the council does will improve health in one way, shape or form, and that was the reason for public health coming over to the council, was to harness all the great stuff that would be going on in my colleagues' departments and use that to make the council the most health improving organisation we can. That doesn't mean they're relevant that they are eligible for grant funding, because that's then limited to kind of public health services like substance misuse and smoking, as I was saying earlier. But what we have got is there is bits of additionality, as we call it. So I think about some of the children and family services offer services within the council. If you think about kind of stuff to do with healthy eating in the context of family hubs or something like that, that is something that we can pseudo commission from our children's colleagues, and they can deliver it on our behalf. So you're looking for the bits which are kind of public healthy, if you like, above and beyond the general sense of they're good for health. Over the years, we've sort of had a target around that. That's laid out in the figure at the top of table 1, that original prior year budget. So you can see that over the years, we've had to do a bit of service transformation and make a few cuts to make certain that we can fund those eligible services to the level of just over £2 million, as you can see there. So that is the link between the public health budget and the medium-term financial strategy. Having said that, that figure is not increasing. So I'm trying to find the right paragraph, but we haven't put forward any savings targets within the public health budget. And I'll come on to that bit, I suppose, in paragraph 16, because that's our pressures and that's how we deal with it efficiency-wise. But essentially, we've done everything we need to do to free up the £2 million to then spend on eligible services in the rest of the council. Last bit before I stop then is paragraph 15. I know when we do the kind of more general update on public health in mid-year in June, probably go into a bit more detail, but it just lays out the standard sense of what are the areas that we can spend the public health budget on. Over the years, you know, it's always the big hitting areas, the things that really cost us money. You know, nearly a third of the grant going on children's public health 0 to 19. People always say, what's that? And it's the health of the service. If you think about a team of over 100 health visitors in Leicestershire going out doing the healthy out child checks, staff costs plus overheads plus your mileage and the rest of it, that takes up a third of my budget. Providing substance misuse treatment services, again, costs a fair whack of money, as does sexual health, which is the sexually transmitted infection clinics, contraception, etc., etc. So that has been fairly consistent over the years, and as I say, there's about 2 or 3 big areas that chew up a good 2/3 of the budget, which are our kind of statutory duties, all the things that make the biggest contribution to the health of our population. So that sets out the grants, where we relate to the MTFS and the overall budget position, and I will pause there.
Thank you. Jewel, you wanted to...
Happy to go first, Chair. Thank you very much, Mike. Thank you very much for presenting this bit. Welcome. Anybody is welcome, especially after the few lean years that we've had. previously, and the 3-year settlement's good. At least we can forward plan as well. Mine was more of a technical question on the ring fence of a ring fence. Is that you said that money was ring fenced to those 2 areas, substance misuse and smoking cessation. Is that included in the TART in number 15? Those amounts, and if they are, then does that mean we've got 2 million spare, or just over 2 million spare, because you'd projected to spend 31 million anyway, and we've got a bit more money, and that bit more money said we have to spend portions of it in there, and then when you minus everything away, it says minus 2,086,000. Is there any plans to spend that money?
Yeah, so that's so 2 bits to that. First bit is yes, the ring fences within the ring fences are included in the table in table 2. The 286 is that figure, so that's the figure that is spent on other services outside the department which are eligible. So it's not unfortunately it's not a spare 2 million quid, but I suppose it's the way you budget it. Is it? I know Sam will know. It always used to confuse the hell out of me the way it was done, but it's in essence it's kind of like, here is our departmental budget. We've spent that. At the end, there is a net £2 million because we've worked that figure. That £2 million we're then spending on stuff that otherwise would be covered by the NTFS within the council. Okay. Sam, is that the first time in 15 years nearly that I've done it right?
Certainly is, Mike.
Councillor King.
Yeah, Mike, thanks for that. That's a very strange thing they're doing, ring fence within a ring fence. So my question that came into my head was, what happens if you don't spend that money, the ring fence money within the ring fence? You know, because there's potentiality for you not doing that. So what happens to that money? Does it get clawed back? Are we able to switch it into another budget stream? And just having done a quick calculation, I see that 4 items in the net budget are actually 71% of the expenditure. It doesn't leave a lot for anything else, and it's somewhat. I'm just kind of curious how they've come up with these kind of scale of increases, because when you start talking 20-30% increase in your budget and then being told, well, you got to spend that money come what heck, basically, that's a big ask in 1 year. So just want to understand that. Thank you.
That's a good question. Generally, yes, nature of grant funding, isn't it? You don't want to be a penny overspent. You don't want to be a penny underspent. For fear of having it taken back off you. Generally, on the public health grant overall, one of the things that they've got tighter on is the amount of money that you can keep in reserve. So anything you don't spend has to go into a dedicated public health reserve, which we can take forward into future years. But there is a limit on that, and I'm looking to Adrian because I think the limit's probably about 10%, isn't it? £1 million, one of the two, 10%, 10% of the budget. So we have to be careful overall with the grant to make certain that we spend an appropriate amount, because you're right, if we consistently underspent, then there is a risk of clawback from DHS. It'll go, well, hold on, you obviously don't need it, so we'll have it back in the centre. So we do have to watch our reserve spend. I must admit, I don't know if they said anything yet about if you underspend on your ring fence within a ring fence. I would assume the same rules apply. And when we submit our plan in March for what we're going to do around substance misuse, for instance, that they will hold us to account on making certain we deliver on that plan, because that's what they want to see, and that's why they have rolled in the supplementary grants into the whole. But Adrian, do you want to add to that?
Yes, just in terms of that, we have got some experience with the smoking grant, which is the other grant that they've rolled in, and both of those grants have specific returns that have to be done quarterly. Some authorities that hadn't spent or didn't look like they were going to spend their allocation during the course of the year had the remainder removed and didn't have it put back in for the future year. So the 5-year allocation for smoking, for instance, some authorities had their allocation over the life of the first 2 years dropped by half, with no guarantee that that money will go back, on the basis that they just didn't spend it. So it wasn't clawback, they just weren't giving it. So we do a quarterly return. We then get reimbursed for the activity effectively that we've done in that quarter. Yeah.
So I suppose really what I was trying to get at, which didn't, which just follow up was, out of the increased spending in these areas, is that just increased spending because we're going to need more people, or we're giving more money to the people we've already got, so it's just getting absorbed by wages and expenditure on staff, or is it actually going to be linked to outcomes, i.e., is the money there because we need so if it's about smoking cessation, it's going to be linked to getting more people to stop smoking, or getting more people on the stop smoking program, or whatever these measures are. Does that go alongside the KPIs, and if so, when are we going to get kind of sight of what those KPIs are that we're kind of linked, or has the department, I don't mean here locally, but nationally, Department of Health, are they setting those KPIs for us to follow, or have we got any local kind of swerving room, so to speak?
Largely nationally set, so it's almost easier to talk about the substance misuse one. So although it's been rolled into the grant, this supplementary grant that we've been handling, it's called DATRIG, it's one of the bullet points. It's the same kind of thing. What have we spent that on? The centre have wanted to see more money going into expanding the number of inpatient detox beds, for instance. So we've commissioned additional beds from that. That's then tied down to both kind of output measures. So they've been kind of going, well, how many beds have you commissioned then extra? And that's also then related to our, I forget what the target is, what the KPI is, but it's kind of like your percentage in treatment, the percentage that have a successful treatment as in they don't relapse after once they've come off drink or drugs. And that has always been fairly good in Leicestershire, but that is showing signs of increase. I haven't got the figures in front of me, so you're going to have to believe me on that one. But that's basically what they're looking for. So when I talk about this plan that we need to submit in March, there are a number of things that we've done based on their guidance with the supplementary grant that will roll forward into the next 3 years. But to answer your question, yeah, it's not, to some extent, it's not new money, because I guess it's grants that have been folded into the overall whole. And they have specified by talking about treatment, recovery and prevention what they would want. The focus has been on expanding treatment and recovery capacity, and we are seeing signs that that's having an impact in our KPIs, which is good. I'm having an erring because if there was any spare within that group, I'd love to be doing more around the prevention bit, because I think we've had a focus on treatment and recovery. I can understand that. Actually doing more about preventing alcohol and substance misuse harm in the first place would be the bit we've always been light on. So if we do have an ability in the plan to do that, then that's where I'd want to take it.
Okay, thank you. Do you want to move on to the budget growths and adjustments and more forward looking?
So budget growth, growth is a very easy one to do. So as kind of, because we're grant funded, we don't put any growth bids in for the general fund, because I know what the answer would be, and it wouldn't be yes. So there's no point. So from that point of view, from a grant point of view, we consume our own smoke. And that's kind of covered, I think, in terms of paragraph 18. I'll come back to paragraph 17. So growth, as the MTFS goes, there is none. What pressures are we seeing in terms of growth on our budget? There's twofold, one of which is wage increases, as you'd expect. National insurance contributions, obviously our providers have to pay the increased NIC contributions. Agenda for change is the kind of NHS pay scale. So we have our own, obviously, inflationary pay pressures through pay awards that council staff would get. But then you've got your agenda for change pay awards as well. In some years, that's been kind of tracking above inflation. So wages is a big one where we need to consume our own smoke, as I say, within that. Then we have a number of demand-led services, one of which we're controlling well. So sexual health, you can obviously, you know, if you've got a sexually transmitted infection, you just need to turn up and get treated. You can't deny people treatment for that as part of the NHS. Health checks is the other one where we, over the years, took a number of steps to be more efficient. But what we're seeing is post-pandemic an increasing number of people coming forward for their health checks. Very difficult to argue that that's not a good thing, because that's what they should be doing. But it's actually put a bit of a cross pressure on, because we weren't expecting people to come forward in the numbers that they've had. So our growth comes from demand-led services and pay pressure. We will manage that within the department and not call on the general fund. Then in terms of savings, again, as it relates to the MTFS, we haven't put forward any particular savings targets because of the nature of the ring fence grant. As I say, the work we've done means certainly for next year's budget, we balance out okay. we do have potentially cost pressures in the latter stages of the 3-year funding settlement, but we will work up the efficiencies as we always do if we need to scrimp and save to balance the books on the public health budget in those latter years. Do want to talk about the efficiency review, which is obviously a really big piece of work within the council, having some really productive conversations with Newton around that. And again, they're very clear for them. I think it's welcome. Improved health, particularly if you focus it on some of the high cost areas that maybe adults and children have got. And I use falls as an example. If we do something about falls prevention above and beyond where we're at, that's a cohort of people that would be in danger of then falling into reliance on what would be high cost adult social care services. So Newton definitely coming at it from a point of view of making the most of the public health offer to help us reduce demand on our other services. So it's not that we are not part of the whole corporate body looking at the efficiency review, but it's welcome stuff there really, which is about celebrating what the public health services can do, not just for improving the health of the population, but the knock-on effect in terms of managing demand within the council. Which is probably all I need to cover, I think.
Any questions on that? To be fair, I think it's all fairly self-explanatory for the simpler organisation departments. James, you wish to?
Just a quick question to sort of clarify my understanding. So effectively, because we get a grant, we only spend the grant, we don't spend more or less than the grant effectively. With the wider Newton review that's going on, is that effectively like an added extra? Because even if they save money, it's not going to affect the wider council budget. Is that what you're saying? So it's good to do because obviously it's always good to be as efficient as we can do. But no matter what they find, it won't affect the budget gap that the wider authority has.
Not directly as in a shift of cash from one budget to the other. I think there is an opportunity there that the more, the more we make the use of public health services, the more that then plays a part in not so much cost reduction as cost avoidance. So if it falls as a classic, and it's kind of like, well, hold on, there's no point taking £1 million off the grant to put it in the MTFS because you can't do that. What you can do is look at what we're doing around falls prevention and thinking, are we maximising that? Are we making the most of it? If in doing so, we then reduce the number of falls, it's not just a saving to the NHS, it's a saving to adult social care as well. So there is a link, but I suppose it's more about future demand growth, choking off that demand growth and the efficiency, cost avoidance as opposed to cost reduction, I guess, in that one.
Okay, thank you very much for your patience. And we'll move on to the next item. Thank you.
Okay, thank you.
Next one's a look at pandemic planning.
I know we've got a Nuge and a meter, but I think
yes, we have.
Stay, if you don't mind.
The mic's going to stay
as well
because it's part of public health. Got a meter. Shudaz Sama, Head of Emergency Preparedness, Resilience and Response at the Integrated Care Board. They have really snappy job titles there. And Anju Patel from Public Health. So who's going to lead on that, presenting on this, or is Mike? I'll leave you to sort yourselves out. Who's going to?
Thank you. Yeah, I'll introduce the item and Amita will take us through the detail. So really, we're just bringing an introduction to pandemic preparedness across LLR, and in the paper, it sets out where we are, what we've learned, and the practical next steps that we're looking for your support so that our system is ready for any potential pandemic threats in the future. The National Risk Register still places emerging infectious diseases amongst the UK's highest impact risks. For us locally, it means that keeping our plans current, exercised and joined up so services can stand up quickly and so that inequalities don't widen. We've learned a lot from the COVID-19 pandemic, and it showed us that pandemics don't affect everyone equally. People in the more deprived communities and some ethnic minorities groups experienced higher harms and slower recovery. There is a statutory responsibility on us under the Civil Contingencies Act. Local authorities and NHS bodies are Category 1 responders. So we must assess risk, maintain emergency and business continuity plans, and cooperate through the local resilience forum. And then under the Health and Social Care Act, the Director of Public Health has responsibility for health protection and for the local authorities' role in planning for and responding to risks to public health.
Thanks, Howard. So from a planning perspective, this is something that happens all year round. It's not something that we just plan, we write a plan and that's it. It is continuously monitored. But this year especially, there has been 3 major exercises where we've tested our pandemic planning. First of all was exercise Tangra, which was an ICB-led exercise. It focused very much on the health elements to test and improve our preparedness and the response of all health organisations in the event of a pandemic, regardless of what that pandemic will be. And it was mandated by NHS England and the Department of Health and Social Care. Following that, we had exercise Solaris. This was a local resilience forum, LRF-led exercise. And that was to gain insights on how the different sectors, especially local authorities and the voluntary and community sectors, would coordinate a pandemic response so that tails into the NHS response. So where we'd looked at Tangra, the NHS, this was very much local authority, voluntary sector. And then to end, we had exercise Pegasus, which was a national UK HSA exercise mandated by the government. So we had ministerial play. It was across 5 weeks. So the ministers would play their part, go down. So it was almost like a real life pandemic situation that they wanted to simulate. So LLR took part in all 3 of those exercises, and that's brought a lot of learning to us. So it's influenced our plans. Organisations will have individual pandemic plans, but as the LRF, we also have an overall plan that we would exercise. We exercise it, we test it, everybody knows their roles and responsibilities, and that's what we maintain. So resources was one of the big things that came through on all of those exercises, and it was things like PPE stock levels and supply chain. We have no access unless that comes through central government. So that's where we would go as NHS organisations. We would go to NHS England, the Department of Health, to say we need PPE stock levels. It's not equitable across. So, for example, GPs aren't included as NHS bodies for PPE. They had to source their own during the pandemic, which was a real concern. Care homes, again, they had to go out and start sourcing their own PPE. So these are all the things we fed back to government to say, if we ever had another situation like this, this is where it needs to be equitable and equal access. So that was it. Testing and vaccination, which was another one. We exercised our capacity. We've got flexible plans in LLR. With that, we can, pull out the old plans and look at what we've done previously. However, we have lost a lot of that knowledge because people have moved on, they've left, etc. So it was important for us as an LLR Resilience Forum and organisations to make sure that we're retaining that. It's written down and we have these in our plans of what we've done previously and how we can adapt that. We looked at workforce because, surge in staffing protocols, how we would staff it, redeployment, etc. Each pandemic is going to be different. It's going to have its own different challenges, but that bit of it, we're still going to need staffing and we're still going to have staff who are going to be affected by the pandemic. So we looked at that and we focused on staff wellbeing and resilience as well during those periods of increased demand, because I'm sure everybody's aware there will have been a lot of people who were doing 16, 17-hour days during that pandemic and the initial response. But we have to make sure that we are looking after all of our staff as well during those periods. Communications, this was another key one about not just how we communicate within organisations, but externally as well, how that communication is led, what is coming from the central government team and national perspective, but also what we are doing locally to make sure that we're having a proactive response to misinformation. We have consistency in all our communications to avoid mixed messaging, accessibility and inclusion in all our communication, which was something that probably wasn't prevalent during COVID while we're trying to send up a fast response. But that's some of the learning that we need to have, that inclusion and accessibility, pre-prepared messaging and community engagement and feedback, command and control. So that is how we oversee any incident, regardless of whether it's a pandemic or a major road traffic collision. We've got really good structures in place that we regularly exercise and test in LLR. We have clear triggers and we exercise those. So we will have a series of tactical and strategic coordinating group meetings, for example. We are going through a process where we do immersive training. So we train those chairs, the potential chairs, attendees of those meetings, so they know what their expectations are in an incident scenario. Obviously, through all the exercising, planning and testing, we have come up against a number of risks and challenges. So funding mechanisms, for example, which is always a big one, local authority, health, etc., accommodation support, isolation support, sustaining readiness during inter-pandemic periods. So, for example, PPE, it has a sell-by date, so we couldn't just stock up. And lots of people, this is what people say: why don't you just have loads of PPE? It's got a sell-by date. It won't work, you know. So we can't stock up. It's a waste of money. But how do we make sure that we are ready for that? Workforce fatigue and retention. Building and sustaining public trust. I think after COVID, we're very much aware that there will be an element of the public who won't, you know, want to abide by any rules, regulations, laws that come in, whether it's stay at home, social distancing, etc. So that is what we have put back to the government through Exercise Pegasus to say these are things that we see as potential issues. Addressing health inequalities, food, medication and PPE supplies, and legal requirements. So overall, I won't go through everything that we've learned, but in the conclusion, what we have found is, as Leicestershire and Rutland organisation and as an LRF, we have the robust foundations in place for pandemic preparations. We have clear proposals, we've got our guidance, and we regularly exercise and test our response and command and control.
Thank you. Sphinx, say something.
Yes, thank you, Chair. So thank you for that. But what would be extremely helpful to add the outcomes of exercise Tangra, Solaris, and Pegasus. What you said you found out things, but what are those things? What were the strengths, weaknesses? What if, you know, got no information?
Yeah.
So I'll just make the point that I was the leader at Harbour District Council in 2019. So I was a leader during the pandemic. Communications, and there's no criticism of anyone, but the communications from the top down locally was poor.
Yes.
Okay, very poor. And despite raising that consistently with those who allegedly were in charge, it never changed. And I resent that. And I've never been asked ever for my view, ever to feed into a local review as a local leader, as I was, about what happened, what could have been done better, what shouldn't have been, you know, none of that. No one's ever come along and sought a view. So I just feed that back now because this is the first opportunity I've ever had to do this. And that was 6 years ago, nearly to the week that the pandemic was declared. So I just find that slightly concerning. I know there's been a national inquiry which has hosed 200 million quid or whatever it is on it. And I'm not really sure we've learned a great deal from that, to be quite honest, that we didn't already know. So I think there is a lot in this, but actually, unfortunately, locally, those of us who were in a position of, political leadership, we haven't been engaged in this process. So it's, officers talking to officers in different organisations, and that's great, but no one's talked to us about it, or certainly people like myself, as far as I'm aware. And maybe you've talked to whoever the lead member was at the time. I don't know. I've got no idea because it doesn't tell me that. But I just think there's something missing here, and that I think is a really important thing. So we haven't looked into. So whether we've, I know you've engaged with maybe local stakeholder groups and this, that, the other, but not entirely sure that we've actually ever done across LLR. We've actually done a review of what did our residents think worked well, what didn't work well. because I think actually we've missed whether we missed the opportunity now. I'm not sure, because I think we ought to have done that, and I'm not sure because we might have found things out that maybe we didn't know, you know, the good and the bad, and there was a lot of good stuff that happened, and there were some things that didn't work as well as or any of us wanted them to. So, and in terms of exercises, if you're going to have exercises, I think you've got to involve, because you know, as a councillor, I've been a councillor a few years. I've never had any training about civil contingencies or civil emergencies. No one's ever come along and said, well, you need to attend this. Okay, I've sat through resilience training, but that's not the same thing as taking part in an exercise. What's the role of the elected, you know, because obviously the powers, civilian contingency powers kind of push us to one side to an extent, but that's really important to understand that before you get to a real life situation, which, to be quite frank, I've said this elsewhere, nothing you've ever done in your life can ever prepare you for it. And I'd include, you know, officials in that as well, unless you've been through it once before. Nothing can prepare you for that. And so I think it's really important that if we are going to do these resilience exercises locally, that elected members, whoever they are actually involved in that process. Because for me, that was a huge gap. You know, I knew it existed. I knew there was stuff going on, but no one, and because we had this upper tier, lower tier nonsense going on, there was a reluctance at the time for information sharing. You know, I'm not saying that Mike wasn't sharing because he was the director of public health at the time, so I'm not criticising Mike, but there was some reluctance from other people, rightly or wrongly, to share information, and it kind of got a bit of us and them at times, which I don't think was in anyone's benefit at all, and just added to the frustration and everything else that there was at times. So I think it's really important to be prepared, because that's a good thing to be, and an exercise. But if they're going to be exercises, they need to involve people like us around the table who are in those positions at that time, to say, so that when if there is another situation, we've at least got some people in elected office who know, this is what's going to happen. I understand this, rather than we've all got to learn again what the process is and what's going on. Because I hope you take that in the spirit.
No, I've taken it in completely the right spirit, because I agree with everything you've said about the communication, and that is what we.
It's not just about that. It's also just about involvement and just the whole overall thing of a sense of, well, you just kind of, there you are, you get on with it, and hang on, well, what we're supposed to do then? You know, and obviously at the time, if you're a leader of a council, and you've got members of the public coming to you, you've got other stakeholders, senior managers, directors coming to you saying, well, what do you want us to do? And you go, well, we've got to wait for the minister to tell us on some Teams call, and you're talking about 16-hour days, 7 days a week, you know, and that's another drain on you as well, because, as I say, nothing can prepare you for that. So I think that is a really important thing, and I speak from some experience, you know, my experience of that how do you then support people who are in those lead roles to deal with the stress and the strain that it creates on you and your family and everyone else around you who you know, because there were things I was told at the time that I couldn't tell anyone else. I was told you can't tell anyone else this, not even your nearest and dearest, about certain measures that might have had to be implemented, given what may or may not have happened with the COVID-19. Fortunately, those measures didn't have to be implemented, but I still can't tell anyone about those measures, which, you know, does, you know, put you under a lot of pressure. So I think that's why I mention it now. But as I say, no one's ever come along and ever asked me, or as to the best of my knowledge, anyone else, what do you think we could have done better? What do you think we did, you know, to get in, you know, to almost like a debrief, really, of what happened. It's never happened.
So what I will say is I completely agree with everything you've said, because we were done to as well.
I know
we were waiting for ministers to
I
tell us.
I know.
Conflicting information as health. We had to wait to make the patient decisions about patients' health because they wouldn't give us an answer. In some cases, we've just had to do what we thought was best for the patient. So all of that has been fed back. Whether we get anything back from Exercise Pegasus is a different matter, but we have fed that back. We have had debriefs. So there were a number of debriefs done by local authority area. So as much as I'd like to say, you know, I don't know who was included in those or not. We had health specific debriefs, but definitely I will be feeding back to the LRF about some of the exercises we do and including counsellors, because I think that's a great point and very valid. What we have to remember is with national tier 1 exercises, as they call them, that are mandated from the government, they tell us who to invite and they say, this is who you need, this is who you need, etc., etc. But that doesn't mean that we can't add people on. So I will be speaking to my counterpart at the LRF to say, let's start including counsellors.
Well, it needs to be the appropriate people, you know, the people who are holding the office at the time. You can't be people who usually do it. You know, so I'm not in that role now. So who knows in the future? But there you go. Thank you for that.
Thank you.
Sure. Cheers. Thank you. I won't keep this long. Mike and his team came into the fore at that time, and it was a blur now. But yeah, what intense pressure you must have been under.
Blur for us.
What intense pressure you must have been under. But my thing is obviously regarding what we're responsible for and how we can influence things. And this was the most vulnerable. So can you remember care homes at that time? And we were unsure of how to protect care homes, and we didn't get. And Councillor King is right. We didn't get the kind of directions that we probably needed at that time to protect the care homes as well as we could have. So those kind of things, and it's easy for schools because the children don't go to school, and so they'll be at home. So it's an easy thing because we've closed the schools down. It's how we do where we can't move the people, how we protect those kind of vulnerables, and it'd be interesting to see what kind of lessons were learned, that kind of thing, and how you've then adopted that into a strategy to make decision making quicker at that period in time.
So I can tell you about some of the learning we've got from care homes, which was about the PPE and getting the access, the vaccination, etc. So what we've done from a health perspective, the other stuff that you talk about, that has to come from central government. And even now, if we had another pandemic, we've given our recommendations, we've got processes and plans in place, but we can't do things without having that say so. Mike, I don't know if you want to add to this.
I think you got me thinking. I think it's a more general point from what Mr. King was saying and yourself, Mr. Mayor, which is maybe it's for me and Uj and me to take it around, but I guess I was expecting Pegasus to be something that would reflect stuff that we kind of learned didn't go well in COVID, whether it be member involvement or communication, whether it be protecting care homes, the rest of it. If I have a criticism of Pegasus, it almost starts from, I mean, this is what I was saying in the chair's briefing beforehand, kind of assumes that there's a lot in place that isn't really in place, you know, and it doesn't matter if it's not just PPE, which is a more obvious example. No, we don't have a stockpile, but it also seems almost like an army of people who will stand up and respond to this. But that army of people is us all, whether you should have been involved or are involved, who then do it alongside your other jobs. And so I know it's a public meeting. It almost feels like sort of national government feel that there's a resource there which can be stood up. And so how are you going to stand up your plans for testing? Well, actually, you need to work out first off what you're not going to do. Care homes is almost in the mix. I'd sort of be up for the idea of doing some kind of debrief or revisiting a debrief, because there is probably local lessons that we've learned. And rather than relying on the national exercise, which probably comes at it a different way, just go, well, what? Not so much wait for direction, isn't it? I'm trying to think what the phrase is, but you know what I mean? At least have a plan in our own mind that if X happened or Y happened or Z happened, what would we do? You can't ignore government advice, but you know, you might look back at it and go, actually, we need to have a plan for how do we balance the needs of people to visit their loved ones, even if they're dying, versus protecting the rest of the population. You know, just have a think about what that would look like. And care homes themselves, you know, did some really innovative stuff and trying stuff in difficult circumstances to try and balance that. So, you know, I guess we've been waiting on these exercises to test our plans and to give us answers, but no exercise is ever going to do that one. And maybe we just need to think ourselves about what would we want to do different. Maybe that's the next stage of me to
I think just an observation. It talks about like, voluntary sector partners. There was a whole army of people just popped about of nowhere, nothing to do with the voluntary sector, who organise things in villages and towns, and that these exercises haven't reflected that at all. And that's where your army will come from, but it'll just pop up, and there's got to be a way of managing that. But it doesn't look like it's been considered in any of this. That's a whole separate discussion. Mrs. Knight.
Done 3 exercises now, and you've obviously gathered a load of do's and don'ts, and you've embodied these into a command and control document. Yeah. Is it possible for all councillors to see what will happen if a pandemic did kick off? What is the first thing that will, happen? What is the stepped process for controlling a pandemic?
So with command and control, regardless of what the incident is, as I said, it would go to an LRF executive meeting. That would be stood up, and that is senior executives from all organisations, health and social care, police, fire, etc. So that would be our first point of command and control.
But wouldn't we as Leicester wait for them to tell us what? We'd already have things in place, just like the gentleman has been saying over there, people in the districts, you'd have people, a communication network that you'd go to, you just wouldn't wait for.
That's the nature of the Local Resilience Forum is a partner organisation, so all districts are on it as well. I'm trying to remember if members are actually directly on the LRF exec. I'm looking at Mr. Cow, I don't think so. So that would be then for individual chief executives of districts, for instance, to communicate with the lead member. But in terms of all the comms networks and stuff, that is the nature of the LRF partnership.
Sorry, but I work in IT and we have command and control documents, and it states step by step what we do. Have you not got that? So can we have a look at it?
I can find it won't be pandemic specific. That's what I'm saying. With emergency planning, we have a set of command and control that we implement. So it starts with strategic coordinating groups, tactical. So what you're talking about with command and control in IT is very different to emergency planning command and control. But we have documents in but it won't be individual steps and this is what we do, because we need to see what the pandemic is, who it's affecting. And a pandemic doesn't just happen overnight. It's a steady rise and increase. So it's not a pandemic from day one.
Slightly confused, but a pandemic, I mean, I know they do vary, but there is a process to go through to control that pandemic. Am I talking rubbish?
No, it's fine. What I'd say is that there's a whole raft of plans within the Local Resilience Forum which deals with a number of things under the sun. Come back to your point in the IT bit, it's like our major incident plan. There's a step-by-step card about what would you do. It's like being on call. What would you do if the phone went? So some of that is specific because it is like ring this person, ring that person, ring the other. Pandemic is different to some extent because it's a little bit like lockdown. Our pandemic plan back then would never have said that because no one ever thought we'd do a lockdown. But doesn't mean there isn't a step-by-step guide in terms of who you would need to talk to, what you would do, what your structures are in place to kind of deal with it and the kind of actions that you do. All of that is the work of the Local Resilience Forum. And again, I don't think there's any reason why members shouldn't,
So local authorities will have their own plans. Yeah. So the actions in a pandemic that local authorities take will be very different to what health will take. Whether it's our GP practices, whether it's our acute hospital, whether it's our community hospital, there will be slightly different actions that we are taking to address the pandemic, because we are going to be looking at patient care. That will be our priority from a health perspective. From a public health perspective, it will be about the communication, etc. And then from a local authority perspective, it will be about that, are they going to close schools? Are the care homes staffed, etc. So that's why there's not one overall pandemic plan. Each individual agency will have this. So we've got an overall pandemic, an LRF plan, which we use together. So there is that plan, but it won't have all the detail of what individual agencies and organisations would do.
I was just trying to glean, as a county councillor, if there was a pandemic, Where are the details of what I've got to do?
Well, as a member, I think that's Mr. King's point, which is actually we do need to sort of reflect the member role in there. So there might be a lot, there's a plan the LRF will hold, which will talk about the groups we set up, the actions we take. I think it is an interesting point about the role of members in that one, which I don't think we cover very well, other than a bit of comms.
You seem to remember you did weekly briefings with you or Michael.
Yeah. I mean,
But that was the county council. It wasn't a district councillor, so we were getting regularly.
I think
Yeah, I know. But
districts we probably had a couple of city and county and district meetings.
If I may, Chair, I think there were 3 during the whole of the pandemic, because they had to be convened by the command, the Gold Command for the LRF, which at the time initially it sat with the late Chief Constable Mr. Cole. Then it sat, I think, with your Oppo in City of Leicester, and then I think you had it as well. So there was it then. Was it in the city? Was then became the Gold Command for the LRF,
Yeah,
and then the
Gold.
meeting could only be convened by them.
So Gold Command went me, Simon Cole, and then on to Andy Williams, didn't it? And
Yeah, but there was only certain people could convene the meeting.
Yeah,
and so it was very difficult. So I wasn't on, but the point, I mean, obviously LGR is going to resolve some of those issues, but the point is that until that point, we've still got this tiering thing. But it equally goes back to my point about if you're in a lead member, if you're the leader or you're a senior member, a cabinet member responsible for health and well-being or health, whatever it is, and you're not being briefed about, well, these are the emergency plans for all sorts of contingencies, not just a pandemic, but LRF covers, major things like flooding, fire, all sorts of incidents. And if you're not being briefed and told, well, this is your role, this is what will happen, you'll get a call at whatever time and you'll be expected to come to this meeting, but that sort of level, I mean, because that's the knowledge that members need if they're in that sort of role. But if they've never been told that, as do officers as well, and I expect some officers didn't know they had a role, some of them anyway, in some aspects of this. So that was my point, really.
I mean, on that one, and come back to the plans bit as well, it's not that there wasn't a huge amount of multi-agency working week by week. The incident management team that I used to have that had district colleagues on it, Ivan would have had the same in the city, he had the weekly SCGs. But there is a fair point about what do members need to know? It makes it sound like I'm trying to hide things, but what should members know in advance of a pandemic, and then what should they know during a pandemic? And that's probably the learning point, I think, for that one. It's a bit like, well, yeah, there is a plan. To us, they need to check. I don't think there's any reason why members shouldn't see it, but we just need to check that. But it's the same thing, yeah.
Mr. Poland.
Thank you. And like many around the table, I remember those days well. I wasn't the leader, I was a cabinet at Charnwood at the time. And certainly my experience, I appreciate I was on the cabinet, so maybe I got more briefings than other members, but maybe some Jules' opinion on this is, but I thought we had pretty good briefings both at county and at borough level as well. But Mr. King's absolutely right in that none of us had faced this sort of thing before. And you know, with the best will in the world, you are sort of learning on the job as you sort of go along. So I think that certainly member briefings generally would be good, and member training at the appropriate level. But it sort of goes into my point. How difficult is it to prepare for a pandemic? So not all pandemics are the same, right? So all pandemics are the same in the sense that by definition they are multi-nation health events. But this, you got COVID-19, which again, as Mr. King was alluding to, we were planning for, frankly, World War levels of issues. Okay, thankfully, some of the things we discussed, as I said, never had to come to pass, but it was still an exceptionally horrendous number of deaths. For quick search, something like 200,000. So it was horrendous in terms of the effect on the economy, the effect on society. Is comparable with those two 20th century events. But then if you compare it to something like swine flu, which also, every death is a tragedy, you're talking about 450 nationally, right? So I guess it's going to be difficult to sort of, well, my question is this, are you having to sort of learn what would be applicable to every pandemic, no matter if there's 0 casualties or everyone. Do you see what I mean? Or is every pandemic so difficult that it's difficult to plan in that way?
So with emergency planning in general, we cannot plan for every eventuality. We train, we go to uni, we do emergency planning degrees, etc. But we can never, any disaster management degree, you can never plan for every eventuality. So that's where our command and control comes in how we manage anything, whether it's a road traffic accident, flooding, a pandemic, and that's what our command and control is. And it will start with those meetings, whether it's a strategic coordinating group at an LRF level. If it's to do with health, we will also have the same to discuss the health, the clinical aspects of it. The LRF is that multi-agency of what do we need to do, what is the issue, who needs to do what actions do we need to take, and who is going to be responsible. So the whole LRF will, whether it's fire, police, health, the local authorities, etc. And so that is our starting point for any incident, and then we will look at it from that strategic level, because they will have to make the decisions, they will have to spend the money, they will have to give us the permission. We have tactical groups who will then carry out those actions, and the operational, and they're the people on the ground, so we will have those operational. So it's that 3 level of command. Some people call it gold, silver, bronze, or it's strategic, tactical, and operational. And that is the starting point for any incident. So I can't tell you about every pandemic or anything, because we wouldn't know. I would be going to Mike to say, what is the novel pathogen for this? What do we need to do, etc. Because I'm not clinical. I wouldn't have that. We wouldn't have all that information to begin with. But what we would have is, what do we need to do? So first of all, are we seeing an increase in our hospitals? Do we need to start creating that bed capacity? And it's probably yes. So we're going to be looking at discharging from our acute bed base, from UHL, from the Royal, from Glenfield. We're going to look at the community hospital first, but then they need to go out into care homes. Do they need carers? Do they need continuing healthcare? That's where we come to our social care colleagues to say, this is what we need, whether it's placements, whether it's so that's how it works, because each organisation will have their own focus. For health, that will be creating that initial capacity, so we're not overrun with 28, 30 ambulances outside the Royal. We're not treating people on corridors. We've got that capacity. For police, it may be different, and there may be uproar, there may be, unrest, there may be people not following rules. So that's going to be their priority. Public health, they will have other things that they're working with UKHSA on to find out, what is this? Have we got a vaccine? If not, how are we going to keep these people safe? Do we need to isolate, etc.? So you see, that's when we talk about pandemic planning and how we're going to do it. Each agency will have their individual areas that they will need to focus on from the beginning. But what we do at that LRF level is make sure that we're coordinated and we know what everybody else is doing. So we're trying not to do the same.
Just, I don't want to disappoint you, Anita. I don't know if the police would say that people follow the rules at the best of times, to be honest. So, but is that mix? I just agree with Anita, and you said yourself, like with swine flu, you can't predict everything, which is why you end up with a sense of what are the more global things that you need to contend with. Because unless you could predict the attack rate, how long it's going to last, is it spread droplets, there's the stuff that we learned from COVID, even at the start of COVID, we thought it was just hand to hand, it was wash your hands, but then it turned out to be airborne. We do get given guidance, so to sort of give you some thoughts about what you want to do. I don't know if it's in the current one, but obviously going back to swine flu days, we're doing pandemic flu preparedness beforehand, and it was prepared for kind of 40% of the population to get it over a 14-week spell, and 2.5% of them would die. That was your kind of upper end of what you need to plan for, and that's what we modelled through with things like our excess deaths, cell, and the rest of it. You need to be careful though, because you can model for that one. But if there's one thing about plans, as we know, it's the old army adage. They don't last first contact with the enemy. So we had all that pandemic modelling through.
And then came COVID, which was not the pandemic flu, it was something else, and it spread in a different way with a different attack rate. So all the plans went out the window. And again, there are some measures which national government had never thought, but we then did, like a lockdown. So, you know, there is that balance, I suppose, between modelling through what might happen, building it into your thinking about the kind of things that you need to do and how you take them forward, but you can't do it step by step because life's not like that, unfortunately.
Mr. Page, you are last speaker.
As someone who was the operations director for Bupa Healthcare in New Zealand, I ran 35 care homes and retirement centres and rehabilitation centres. I was just trying to look back on how many deaths we actually had. Very few. And one of those things is we didn't rely on central government for what we did or to local authorities. We had our plans in place. But we actually contributed to their thinking on developing local and national policy. But I was also responsible for procurement as well, which was particularly difficult at that time, especially being in New Zealand, where we were the last in the supply chain for the rest of the world. But what I would say to you is that if you're planning for the next pandemic, please talk to those providers. I'm happy to help in that situation because we learned a huge amount. And we didn't get the advice from government. In fact, we're the ones that actually prevented the deaths. Had we followed government advice, we would probably have seen more deaths actually in our care homes. We actually saw none. We had, I think, an incident with a cruise ship that came in with 7 people who actually had contracted it, and they were immediately sent into local hospitals. But one of the things that we did was we prevented the transfer, you just mentioned it just then, of elderly into our care homes without screening. They went into a 4 or 5 day screening process before they actually were allowed to go loose inside our care homes. And even then they were under quite strong controls. And the whole ethical question about how families visit and keep contact was critical. It was difficult, really, really hard, and it was heartbreaking in some situations. People died naturally in that time, and it was still difficult for them to see their families and loved ones. And I have to say this, we actually did take a different line, and we allowed some contact, provided we made the channels safe for them to see their loved ones before they died or actually at the process. But anyway, that's just my contribution. I just want to say thank you for doing the work, but please don't ignore the providers that actually do this and incorporate them into your thinking and that experience, and go outside of the UK and get some advice from elsewhere where we did it really well. Thank you.
Can you say that to number 10, please?
Study visit. Well, thank you very much. That was interesting, and thank you for waiting for that. Our next meeting is Wednesday, the 4th of March at 2 p.m. There are no other urgent items. You can all go home. Thank you for your time.